All right, let's go ahead and get started. So great for you all to be joining us today. Thanks for taking the time out of your busy Friday. Really excited to have everyone here to do a full review of the CCSP program, patient navigation, as well as the evaluation components of CCSP. I'm sure, I think you all know me, but I'm Elsa Weltzing, back working full time on the program as the program manager. And Andy Dwyer, our wonderful program director, is also joining us today. I'm going to turn it over to Andy in just a moment to get us started. But in the meantime, if you could all go ahead and introduce yourself in the chat, where you're joining from today, and if there's anything in particular you're hoping to learn from today's training. And I hope you all have been thinking about two truths and a lie for a fun activity that we're going to sprinkle throughout today's training. So without further ado, I'm going to turn it over to Andy.
Okay, great. So thanks so much, Elsa. Sorry, my internet dipped out there for a minute. And can you hear me now okay, Elsa?
Yes.
Okay, great. So yes, the two truths and a lie. So if you guys can make sure and do that, we are going to be calling on folks throughout the day to share your truths and a lie, and then the group will have to use the chat to determine which is the truth and which is the lie. So we'll do some little fun stuff here. We'll go ahead and why don't we have everyone, since I think we have 16 folks on, and we're going to be together for a while today. So why don't we go ahead and have everybody introduce yourself and then share what you hope to learn from today's meeting. So I am going to go ahead and be ready to come off mute so we can keep this jamming. I'm going to go with Alyssa. So Alyssa, do you want to introduce yourself? I know you're writing in the chat, but who you are and where you're from and what you hope to learn today. Then we'll go Anna and then Charisma after that. So Alyssa? Are you there? Are you there? Okay, we'll come back to you. Anna?
Hi, my name is Anna. I'm case manager here with the Lahana Valley Wide Clinic. And I'm sorry, what did you want us to say?
What you're hoping to learn from today, and yep.
I'm hoping to learn how to read the report a little bit more thoroughly.
Wonderful. Okay, good. We could definitely do that. Well, thanks so much for joining. Good morning, Laura. We'll go Laura.
Good morning. Next. Hi, everybody. I hope you're asking this, Laura.
Yes.
I need a refresher. It's always nice to just get a review so that I can hopefully answer the questions that my staff has. Thank you.
All right. Perfect. Great. So let's go Charisma and then Gloria.
This is Charisma. Can you hear me?
Yes.
Okay. Charisma Rascon with Evaluate Health Systems. And just to better identify what the findings on the reports and the pathology reports.
Great, good. Well, we will definitely do that. So you are in good company. We'll go Alyssa, sorry everybody, and then we'll go Gloria. So Alyssa, then Gloria. You know, it might be Elisa, I might be pronouncing names wrong.
Hi everyone, can you hear me?
Yes.
Okay, this is Alyssa from High Plains Community Health Center Lamar, and I'm also just needing a refresher. I started this program a while ago, but I feel like I need a pretty good refresher kind of training to know what's expected and what's to come this year.
Awesome, thank you for joining. Okay, great. Gloria.
Hi, this is Gloria. I'm in Rocky Ford and I work for Valleywide, and I'm also here for a refresher.
All right, there's lots of refreshing. So I love that. Thanks for coming. We'll go Julie, and then after that, we'll go Carla. So Julie R.
Hi, I'm Julie Reinbarger. I'm a case manager at Valleywide at Edward M. Kennedy Health Clinic in Monte Vista. Good morning, everyone. I need a refresher as well. I feel like it's the first day of school because with COVID, we've done a lot of Zoom calls, but we've been in and out with a lot of different changes. So I think it'll be nice today. I'm excited.
Wonderful. Thank you for joining. Carla?
Hi, good morning. This is Carla at Maryland Health, and I'm in the same boat as everybody. It has been a while, and I think sometimes I second guess myself, and I have to, I'm looking forward to refresh everything.
Awesome. Nice. Well, welcome. I love the refreshing. Let's go with Pam and then we will go Tammy. Pam H, are you able to come off mute? Okay, we'll give her a minute. Tammy, and then we'll go Victoria.
I don't know if you guys can hear me.
Yes, we got you.
I'm here to learn because I'm going to start helping Carla do more. So it's new to me.
All right. Well, thanks so much for joining. All right, we'll go with Victoria and then Cindy.
Okay, good morning, this is Victoria. I am looking forward to, like the other girls said, a refresher. It's been like with COVID, you haven't been doing a lot. So then when you go back in, it's like, okay, where am I? So I'm looking forward to just getting a really good refresher.
Wonderful. All right, great. Cindy? Cindy Alexander from Uncompadre. Can you hear us this morning? Okay, we'll give everybody just a minute. Okay, well, I know Pam, thanks for letting us know that your microphone isn't necessarily working, so we'll definitely be monitoring that chat. And you're looking for understanding what tools are available to help manage the clinic. Awesome. And I think we also have Marisa joining us today too from Valleywide. Marisa?
Hi guys, I'll come on camera for just a minute. I'm gonna be a fly on the wall today. I do have another meeting, so I'll be jumping in and out. I asked Laura to send this to me because I'm completely new. I've never taken any patient navigation training or anything like that. I have a good idea about the program and different things like that, but I think I want to learn more about what components are for successful patient navigation for our staff and what those steps entail and what kind of screenings are covered, all that good stuff. So yeah, I'm just excited to learn, not like you guys a refresher, I'm excited to learn it all.
All right, awesome. Well, great. So thanks again, everyone. Is there anyone who I called on earlier that needs to either come off mute, didn't get a chance, or anyone else I haven't hit today? Going once, going twice. Okay, that sounds great.
And if anyone's joining by phone and wasn't able to come off mute, you press *6 to unmute yourself.
Okay, very good. All right, everybody. Well, Elsa, are we ready to get jamming then?
Yes, absolutely.
Okay, great. So we're going to go ahead and start talking a little bit about just the introduction to the CCSP program in general. I'm going to talk a little bit about, of course, so we are a statewide program who specifically work to provide technical assistance, resource, and support for safety net hospitals and clinic systems. So that's all of you who are part of FQHCs, who are part of rural health clinics, critical access hospitals, and then a bevy of clinic systems that are oftentimes faith-based or even sometimes residency programs, but your mission is really to work with the medically underserved because that's what we're all about. So we are excited that we're able to continue the CCSP program for another 2 years. We have an extension for some continued work. We are funded through the Amendment $35, which are the cardiovascular pulmonary disease grants program from the State Health Department, who's the administrator of these grants. But just a reminder that the money really does come from the tobacco tax. So anytime someone uses a tobacco product at this point, the CCPD dollars really do come from that taxation. So for cigarettes, chewing tobacco, right now, this pot of funding isn't for vaping. There's another pot of funding. But one of the big impetus is that the whole idea for CCPD and for the cigarette tax is that it would really decrease smoking, because if we increase tax over time, it would be harder for people to afford smoking and to really deter youth smoking. And what I will say is that that is working. When we first started the program, we were garnering up to about $30 million per year for us to be able to apply for the competitive grants funding. At this point, we're now closer to 10 million a year. So we do know smoking rates are down in Colorado, but we also know smokeless tobacco is something that's still a very big threat to our communities. So these are the funds, this is who we are, and we'll talk a little bit more about the it, but we really are about preventive cancer screening statewide, working with all of the safety net clinics in Colorado who can work with us, have the vision and mission for preventive screening, and then can meet the requirements of the grant. Next slide. So the why, and this is something that I want to stress really importantly, is that Colorado, most states, cancer is not the leading cause of death, but in Colorado it is. So I wanted to say that the Cancer, Cardiovascular, and Pulmonary Disease Grants Program is really supposed to be dedicated to the most lethal cancers. I think we've seen some attrition where we're starting to see more and more of that CCPD money used for other things. And a little bit of it really detracted from cancer. And I just want to say that, this money and this legislation was passed to specifically help with cancer prevention, interventions, cancer control, help cancer survivors. So this is something I think we're going to collectively need to advocate for the years moving ahead about keeping this pot of money really focused on cancer, cardiovascular, and pulmonary disease. But the why is because it is the leading cause of death in Colorado, and lung cancer is the leading cause of death. Colorectal cancer is the the second most common death. And then you'll see right now that even though when we start to look at ultimately the death rates in for all people, or actually, Elsa, I'm starting to cover your area. So I just want to say that ultimately, colorectal cancer is right up there as a very common area, but part of the reason that we moved to really working with working in lung and then also hereditary cancers is because that ultimately lung is a leading cause of death. I'll have Elsa go through this a little bit, and it's one of the more prevalent. But we realized that in terms of the CCSP program, we've done a lot of work in colorectal cancer, the breast and cervical cancer program with WWC, but there really wasn't a lot being done for lung cancer from screening provision, as well as looking at other types of cancer, particularly hereditary cancer that have really strong mortality rates. So also, I'll turn it over to you to talk a little bit about the data and why we're focusing where we are. But again, everyone, we did move from the colorectal cancer program about 3-4 years ago to being the Colorado Cancer Screening Program. And we're going to talk a little bit about the data that's driven us to make this move. So Elsa?
Thanks, Andy. So what you can see here are in Colorado, the most prevalent types of cancer in terms of number of cases on the left, and then by death rate, as Andy was talking a little bit about. So in Colorado, we see similar patterns to the US overall, but in terms of incidence, the top ones are breast, prostate, lung, and then colorectal. Also a couple others that we address as the hereditary focus are uterine, and then sometimes kidney a little bit as well. But then if we look at death rate, lung is leading, followed by prostate, then breast, and colorectal. And so breast has been able to get a good amount of funding for the WWC program for many, many years. Colorectal, not consistently as much funding. And so that's why it's really important to continue to address these leading cancer types. And so CCSP is addressing lung cancer, CRC, as well as all of those cancers that can be due to a hereditary risk, such as Lynch syndrome or hereditary breast and ovarian cancer syndrome, so including breast, prostate, CRC, and uterine. But I have a question for all of you. This is looking at men and women overall. So does CRC predominantly affect men more than women, or is it about equal? So let me launch our poll. And just go ahead and put in your answer. Does colorectal cancer predominantly affect men more than women? Yes or no? All right, got about 10 answers coming in. Let's see if we can get one or two more. All right, last call. Okay. So, we got a pretty split response to this one, with about 42% saying yes and 58% saying no. No is the correct answer. CRC affects both men and women at about an equal scale. And of course, sometimes men are less willing to get screened than women. So it's really important that we're trying to reach both men and women for colorectal cancer screening. So some of these cancers on this list, of course, like breast, predominantly affect women, while prostate, of course, being a male cancer. However, colorectal affecting both men and women. So when we're thinking about screening, really important that we're trying to reach both genders and sexes. Okay. So with colorectal cancer as the core of the CCSP program, we've been monitoring screening rates and late stage incidents over the course of the program. This data is from 2014 to 2017, so about 5 years old now, but most of the patterns are still similar and relevant. And this map shows the regions with the highest rates of colorectal cancer that are diagnosed at a late stage. That's shown by the solid colored areas in the different regions of the state. And then the colorectal cancer screening rate for each of those regions, which is indicated by that circle. So the darker the color and the smaller and darker the circle, more late stage incidence and a lower screening rate. So just take a moment, look for your region where you work on the map, and thinking about a little bit about that incidence and the screening rate. We're really trying to help you all raise screening rates in your region, really with that overall goal of prevention and early detection for better outcomes for patients. So we've definitely seen some improvements in Colorado over the years, but definitely still some work to go. And even in those areas with the highest screening rates, still trying to reach that goal for the state and nationally overall of 80% screening compliance. So a lot of great work has been done, and thanks to all of the work you all do with reaching your patients, but still more to do to try to reach those who need screening. So I'm going to turn it back over to Andy to talk a little bit about our CCSP services and activities the program provides, and then the eligibility criteria.
Okay, wonderful. And then what I want to just say about the last slide, I know that sometimes when we're in person, we really literally come up to the screen and look at what's going on within our state. These sort of tools can also be super helpful, I think, in terms of messaging to patients, to clinic champions, as well as even sometimes policymakers about what's going on in the state. So I put in the chat, I'm from Cheyenne Wells, Eastern Colorado, Cheyenne County. What I always notice is that our screening rates are really, really low. We don't have as late stage diseases we see maybe in Lamar or up in Holyoke, but I also see that in that county, in that general region, it seems like the income levels are a little higher than some of the other parts. So those are the kind of things that we take into consideration for program planning, but I think using the data that Elsa has provided can be really helpful for you to really think about your messaging and what's going on in your community, and something to watch over time, as Elsa had said. So definitely spend some time with that data and think about, like, what does it mean for your community? We always have access to additional data sources. So if that's something that we need or can be helpful, let us know. We also have a strong partnership with our state health department to pull data pools as well. So that's something we can help with. So moving on. So what does CCSP entail? The things that we are providing at this point are really looking at systems approaches to increasing screening for colorectal cancer due to risk. So the lung cancer, the colorectal cancer, the hereditary risk, we're really looking at systems approaches and really looking at how we provide technical support about the information about the disease, what are the evidence-based interventions to help really look at decreasing those in terms of death rates, mortality, late-stage disease. How do we help with prevention and control efforts? But the biggest part of that is navigation. And so really thinking about how do we provide technical support for you all in terms of the colorectal cancer screening navigation into colonoscopy. How do we look at maybe how we really look at capacity building for lung cancer, hereditary cancer moving ahead, and also stool-based screening moving ahead. And how do we build that capacity in terms of meeting you all where you are, whether that's navigation approaches or whether that's looking at other types of opportunities. So what I will say that will stay at the core is we will always continue the colorectal cancer screening into colonoscopy. So that's still the cornerstone of the program. But if you're a clinic system who's really interested in looking at increasing colorectal cancer screening through FIT and FOBT approaches, stool-based approaches, if you want to move the dial and really think about capacity building for lung cancer and hereditary cancer, that's something that we're really going to be working with all of you moving forward. So when we meet one-on-one, we are going to have some discussion with you about where are you in terms of general implementation of colorectal screening and navigation? How can we support you? But for the lung, the hereditary, and even stool-based screening in the future, what are some things that you'd like to do? We do have a set of pots of money that if there are certain things that you'd like to take on for capacity building in those areas, that's something that we can do this year. And again, when we meet with you one-on-one, we're going to spend some time really devoted to that. We will be continuing to do the regional trainings with all of our navigators and community partners. We'll be doing these sometimes in concert with the local public health agencies. We will be doing this with the Cancer Coalition. We'll be combining forces with WWC and CPED. But we really do want to think about meeting you all in your communities when we can, because of COVID restrictions. That's been difficult. But we really want to try to provide some more technical support going to your clinic systems in your regions. Clinic outreach and patient support services. We do have a modest budget. So if you're interested in materials for patients, if you're interested in maybe radio or support for a local newspaper, we have information about how do we promote preventive cancer screening services. And sometimes, again, we can do those in partnership. But we'd love to know from you all, of course, as we go through what you're interested in. And then, of course, the dedicated approach to sustainability. So I think, the one thing that we want to also just mention is that we know that CCSP will not stay as a program probably beyond the next 2 years. I think we're sort of lucky that we've survived this long because that Amendment $35 that I noted before, they have asked that, that different types of funding mechanisms find other means to sustain their work. So that's something we've been working with all of you, is thinking about how are you sustaining the navigation preventive screening? Where are you moving when CCSP goes away? But what we're also using and taking this information is to essentially share with policymakers, payers, and others to say, navigation is an area that needs to be supported. How are we going to do stronger workforce development? How are we going to really make sure that we can look at fee-for-service reimbursement for navigators, that you get fair and equitable wages? So this is something that we're still working towards, but we're really going to need to work with all of you to say, while we're getting that together, how are you able to help support this navigation work within your system with your leadership? And then the other thing I wanted to mention, of course, is that we do have some limited dollars for barrier reduction funds. So if you have patients who are having a difficult time with transportation, bowel prep, elder care, child care. Those are things that we can provide some support for the program. The only hook there is that we aren't able to independently reimburse patients. We would have to have you as a clinic system basically provide an invoice, and then we would be able to reimburse you, and then you would be able to provide that support for patients. So I know we've seen a couple different systems who, again, for transportation, for Uber, for bowel prep. So we have those. It's a get it while supplies last. So the earlier that you provide some of those receipts and invoices, the faster and the more likely we are to get you reimbursed, because our program year starts in July. So we're only a month in, and I don't think we've used any of that money so far. So if you have questions about what that needs to look like, following today, we can provide an invoice template. If you have questions, Elsa, myself, or Kelly or Barbara, who are part of our accounting team, can help you out. So here's the name of the game in a nutshell. Everyone typically for our program provides navigation for colorectal cancer screening into colonoscopy. Some of our systems navigate a couple hundred people per year, some actually just 1 to 2. Everybody makes a difference in terms of doing that sort of work. We are going to, again, be doing more work in stool-based testing and open up capacity for that, as well as for genetic and hereditary and lung work. We, again, have dollars for that outreach support for barrier reduction, but we're going to still continue to really need to work with all of you about ensuring sustainability for preventive cancer screening and for navigation moving forward. So that's a lot. Like, that's the core of the grant. The stuff that's really new this year is that really we're looking at that capacity building for lung cancer, hereditary cancer, and for stool-based screening. So let me just stop there and see if anybody has any questions before we talk about CCSP eligibility. Or not, yeah. Any thoughts? Questions? Okay. What I would say is when we do meet one-on-one, we are going to talk about the opportunity for capacity building in some of those other areas that are different than the grant this has been in this last year. So more to come when we have those. And Elsa, I think we actually have most of our one-on-ones set up with the systems this year, correct?
Yes, almost every clinic system has their meeting scheduled. So looking forward to connecting with you all in early September.
Okay, so I think though, before we move to clinic eligibility and who's eligible for CCSP, it's time for one truth and a lie. And we're going to start with our lovely and talented Elsa Weltzing, because I see her right now. So Elsa, I don't know if you knew you were participating in this part of the show, but why don't you tell everyone, and then I'll write it in the chat too, for anyone, for some reason, if there's any issue here. But Elsa, tell us 2 truths and 1 lie, and then we'll come off mute and see who can guess. Elsa?
Okay, and I am prepared. I did think about this. So here are my 3 statements. And Andy, I know you know the answer to this, so don't give it away.
Okay.
I have 2 sisters. I don't know how to whistle, and I have never been to Europe. Which one is the lie? I have 2 sisters. I don't know how to whistle, and I have never been to Europe.
All right. Here we coming in. You know how to whistle. You don't know how to whistle. You can't whistle. There's a lot of never been to Europe, but a lot of speculation about your whistling ability. 2 sisters. What do we got? What do we got?
All right. Anyone else? Last call. Well, Gloria is correct. I am an only child. I don't have any sisters, but I really appreciate everyone's thinking that I have the ability to whistle when I've never figured out how to do that. So really appreciate everyone's faith in my whistling ability.
All right, that's awesome. Okay, so moving on, let's go ahead to the next one. So who is eligible for CCSP? Right now, for the provision of service for people who are navigated into CCSP, we currently are people who have Colorado residents or have been able to show House Bill 1023 verification or been able to basically opt out through HB 1023 verification. But ultimately, those individuals those sites who have HB 1023 exempt status, or that if you are not an HB 1023 exempt status, it must be Colorado residents eligible for preventive cancer screening based on USPSTF or American Cancer Society screening guidelines. So what I'm happy to say, and I think most everyone on this call has their formal paperwork in for the HB 1023. So the verification situation is not something that we have to basically turn in and really be liable for at this point. But the great thing about the recommendations for American Cancer Society and USPSTF is, at least for colorectal cancer screening, they now align. So starting in this next year, we'll be moving from 50 to 45 years old for average risk population to be screening for colorectal cancer. Right now, American Cancer Society already does actually use those screening guidelines, but USPSTF, I think in the coming months will be, they've already made a decision, but they're getting ready to implement that back to 45. So all the patients that you see who have Medicaid, who have Medicare, or who have private insurance, all should be starting screening at 45 years old for average risk versus 50. So what I would just remind everybody is the best screening test, again, is the one that gets done. We will be talking about how to increase uptake for cancer screening, such as FIT-NEPOBT stool-based screening, as well as colonoscopy. But starting at 45 is going to be the name of the game. Some of the lowest screening rates have been those who are starting just at 50, and that's where we saw some of the biggest cancer spikes. So starting at 45 and getting people screened no later than 50 is going to be crucial for really decreasing cancer mortality rates in Colorado. Right now, individuals need to be at or below 400% of the federal poverty level. We do have a program guide. We do have material that can help figure this out. This is based on household, family size, but ultimately that FPL level there is noted. And then you will know that, of course, with working with WWC, CICCP, and any other programs, that this is essentially similar to what those thresholds are. CCSP does not ask you to complete any sort of documentation that we prescribe on behalf of the program. We ask that you verify income using the tools that you typically have, and you validate that within your own systems. So that's not another layer of paperwork that we just ask you use an approach to make sure that those who are most need of screening services based on income level are getting those services and are navigated. Any type of insurance, so it doesn't matter if someone has Medicaid, Medicare, private insurance, or is even uninsured, they're eligible to be screened in terms of screening navigation on behalf of CCSP. So if you're navigating any of those individuals, they're definitely eligible for reimbursement. We're asking that they should be a patient that with your partnering clinic, or if you have a relationship with another clinic systems and you're helping navigate those individuals, that you basically have that all in order in terms of making sure that they're clear about all the steps of the navigation. So we need to just make sure that we're looking at patients who have a medical home. We help them make that medical home, and then you're navigating those individuals. And then, as I noted, most clinics have exemption for House Bill 1023 lawful presence requirements. So if you wonder about what's happening for your clinic system, or if you're exempt or not, we will let you know if there's a status issue that we need to double check with you. But I believe everyone in this call is on, so we don't have to be those doing those pesky HB 1023 verification forms any longer. So eligible for preventive screening based on medical guidelines, 400% of the federal poverty level, insurance type, any type or no insurance, a patient that you see within the clinic system that you're helping link with medical home. Those are the folks who are eligible for the preventive cancer screening navigation and for that reimbursement. Again, for those areas, we're going to be looking at stool-based capacity building, lung cancer, as well as for the hereditary. I do suspect that there will be some of those areas where you're really looking at helping patients navigate or building capacity in that way. Those will be really not the same area where we're looking at eligibility quite the same. And they may or may not be, but right now this really focuses on the colorectal cancer screening navigation, where you're providing a service and a navigation for a patient. Those other areas are going to be more capacity building, but that's still a little bit to be determined what that looks like for clinic systems who get those small awards. Next slide.
Before we move on real quick, I did have a quick poll just to double check eligibility and making sure people are clear on who is eligible for CRC screening through CCSP. So it's a select all that apply. Who is eligible for CRC screening? People at average risk, high risk, people with symptoms of CRC, people older than 50, people younger than 50, uninsured individuals. So give everyone a moment to respond, check all that apply. All right, 10 more seconds. All right, we have 9 responses. I'm going to end the poll. 10 responses. Okay, so the correct answer, and many people got this, but not quite everyone, is all of these groups. So people at average risk, people at high risk based on guidelines, and we'll be reviewing those, as well as people who need a diagnostic colonoscopy due to signs or symptoms of colorectal cancer. And then really the big point is following those guidelines. So guideline moving to 45 for average risk. However, there are people who are eligible for screening younger than 50 or now 45 due to their family history or genetic risk, or because they're experiencing signs and symptoms, and uninsured individuals also eligible as long as there is a means, of course, to get them screening and any follow-up care that they need. So all of these groups are eligible for CCSP. All right. So Andy, there you go.
Okay. So the overview again of our CCSP activities is really that we're focusing on the delivery of navigation services. So again, with those people that we have talked about for eligibility standards, our goal at this time is to navigate at or more than 2,750 people throughout the entire state. We're really going to look at how do we look at best practices for barrier reduction, for cancer prevention, for the colorectal lung family history, and really looking at coordination of care within the preventive cancer screening services, and really, again, looking at that sustainability of navigation as we move forward. So one of the things I just want to mention too is that we do want to work as closely as we can with our partners who are doing complementary work. So again, I've mentioned the WWC CPED program, the CRCCP program, as well as industry sponsors moving ahead. So hopefully as we continue this year and into next, you'll start seeing more and more opportunities to connect with us and partners who will help continuing this work. One of those, of course, is also the American Cancer Society. And then again, some of our other partners from CDPHE who also have cancer prevention as the name of the game and chronic disease prevention in general. So we're really excited about where we're going for these next 2 years. One of the things I just also want to mention, we will be probably offering some more opportunities for research programs, for implementation programs. One of those that's coming to bear is a relationship with Exact Sciences for stool DNA, and really looking at cancer prevention, utilizing their kits, decisional tools, and thinking about different types of navigation approaches. So we are going to be looking for clinic systems to implement those types of endeavors. There will be money for coordination, maybe some in-kind of support for those tools in terms of the Cologuard kits moving ahead. So we're really just wanting to make sure that, of course, CCSP, we have all of the things that we're doing with you as part of the grant system, offerings and opportunities. The one requirement is navigation into colorectal cancer screening and colonoscopy, but there's going to be a number of ways for you to be engaged with us as we continue thinking with our thought partners around resources and how to further engage in cancer prevention. So also, anything else to mention about this?
I think you covered all of the big things at the moment, and we'll be touching on the majority of those topics, including those opportunities for capacity building and the why around those later on today. But yeah, really excited about these new opportunities, really to support you all, and all of these connect to the sustainability piece, whether or not it's around just colorectal cancer screening and navigation. All of these pieces are connected to the overall sustainability work.
Yes.
So before we move into a little bit more detail around colorectal cancer, the different cancer types, as well as the overview of navigation and what it really means to navigate someone for CCSP into preventative cancer screening, I just wanted to give a quick highlight of all of the successes and outcomes of the program to date that are really all due to the work that all of you do to help support your patients. So as a result of the about 15 years of CCSP so far, over 34,000 people have been successfully navigated into endoscopic colorectal cancer screening. And about 18% of those have been in the rural communities of Colorado, which is higher than the proportion of people who live in rural Colorado overall. We've seen a little bit of a drop in reaching rural communities in this last few years, but we're still really, really dedicated to providing the resources to our rural and frontier communities throughout Colorado. So thank you all who are continuing to participate with us, and we're hoping to provide additional opportunities for those in our rural clinic partners, even if they're not a formal CCSP clinic at this time. Additionally, CCSP has maintained a really strong BAL prep and complete exam rate over the years. I will note there has been some slight decreases in the last grant cycle, but CCSP continues to be one of the highest achieving programs of the CCPD grant portfolio. And it's really all due to the work you all do to help ensure good outcomes for your patient with that adequate BAL prep, making sure that the providers are able to see those polyps and removing those to ensure that they're catching precancerous polyps as well as cancers. So we're here to support you all with continuing to achieve these strong outcomes. But all of these successes are really thanks to all the work that you all do. So just wanted to give a quick thank you and shout out to all of you. Just a quick overview of some of the demographic and characteristics of the patients that have been navigated in the last 3 years of this current grant cycle. Clinics are doing a pretty good job of reaching equal proportions of men and women. As I mentioned earlier, of course, with colorectal cancer being a cancer type that affects men and women equally. Also, about half of the patients navigated have been belong to a racial or ethnic group other than non-Hispanic white. And then reaching a majority of patients with Medicaid, as well as those with Medicare, underinsured, and those with private insurance, as long as they're meeting that income requirement. And people are needing colonoscopy for a mix of screening, of course, as that leading group, but also for surveillance colonoscopy and those diagnostic colonoscopies. And then CCSP has maintained a low no-show rate under 10% at about 6% for this grant cycle. And now we're tracking cancellations as well. And also now better capturing whether the polyp types and their risk for developing into cancer. So about 4% have been reported as those high-risk polyps that have the highest chance of developing into cancer. And then around a 1%, just a little bit under, of patients having a cancer diagnosis. So this is all really important information of why we collect so much evaluation to really see who we're reaching and what those outcomes are. And we'll be talking more about the evaluation later on, but really just wanted to highlight some of those successes, achievements, and that we are really reaching that medically underserved population. So I'm going to turn it back over to Andy. Actually, I have just one or two more data slides. Then I'm going to turn it back over to Andy now that we're going to be talking about the overview of colorectal cancer and the basics of navigating for colorectal cancer and specifically endoscopic screening. So colorectal cancer incidence and mortality rates in the US and in Colorado overall have been declining since the 70s or late 80s in people 50 and older, which is great and largely in part due to screening. However, incidence as well as mortality have been increasing in those younger people, this data being for people ages 20 to 49, rising by about 1 to 2% every year since the mid-1990s. And this is really alarming. And researchers are trying to understand why, and we don't quite know why yet, but these increasing rates have been the driver for the colorectal cancer average risk screening age to be reduced to 45 from 50 in recent years, first by the American Cancer Society, as Andy mentioned, and now passed by USPSTF as well. And the main reason for that being that the greatest increases being seen in those 45 to 49, but we are seeing these trends for people much younger than that as well, and trying to understand why. Although the greatest rates of colorectal cancer, I want to still emphasize, are still in that older population. These rates are rising at a rate so much so that it's predicted that colorectal cancer is predicted to be the #1 cause of cancer death in adults 20 to 49 by 2030. And so trying to make sure we're paying attention to people's signs and symptoms, even if they're below that screening age, as well as opportunities for screening for those that are 45 and older, as well as those with a high risk or family history, is really important so that we can curb this trend. And we're also seeing these same trends in Colorado, where we've seen a decrease in incidence and mortality in Colorado, and then increasing rates in those younger than 50. So just wanted to make sure that you all were aware of that, and that's some of the information around why we're trying to make sure we're capturing screening and providing screening opportunities according to the guidelines for people both older and younger than 50 years. I'm going to turn it back over to Andy to provide an overview of the colon and then some of the information about navigation in the colorectal cancer screening.
All right, awesome. So one of the things before we transition, I do want to mention is, Elsa, I think you're exactly right. Being able to start screening on time now at 45 years old with some of those trends will really direct. So I think as quickly as we can start talking to people about preventive screening from 50 to 45, once those policies take full effect, that's something we can do. In Colorado, it's actually also showing that young women are some of the, colorectal cancer is some of the most increasing cancer deaths in young women in Colorado. So it's interesting right now, I think with breast, cervical, colorectal, we have a chance for combined messaging about prevention well before 50. And the thing we're going to talk about also is family history and signs and symptoms. It's estimated, and Dennis Anand, who you all know that we lost last year to colorectal cancer as well, has estimated that with some of his research and some of the colleagues all throughout the country, is that if we took and if we knew family history and we acted upon signs and symptoms for early age onset disease, we think we could cut mortality by a third. So the preventive screening being like people really knowing their body, feeling comfortable to talking about healthcare providers doing something about it, people knowing the family history, providers helping make those recommendations for earlier screening, that could all really, help really reduce the number of young deaths we're seeing if those came into light. So we're going to be doing a lot of work this year that way as well. But I do think it's actually very, it's sad, and it's actually very sobering when we see those numbers from the number of that colorectal cancer is going to be one of the leading causes of cancer death and maybe all cause mortality in young people moving forward. So something we have to take advantage of. You guys are right in the center to be able to do something about it. And so that's what we need, and you're the army to get it done. So super excited about it. Before we go into my favorite thing ever, the anatomy of the GI, because I'm a big nerd for all things colon, we are going to do, two of you are going to do truths and a lie. So before we go into the bowel, we will go ahead and I'm going to randomly choose Carla and Gloria. So Carla, why don't you come first? And we'd love to hear 2 truths and 1 lie. And then we will have Gloria do the same. So Carla, are you ready?
Yes.
Okay. Carla McCann, everyone, Grand Junction, Colorado. Here we go, Carla, go.
I am originally from Honduras.
Okay, you're originally from, well, I'm sorry, that just came through. You're originally from
Honduras.
Honduras.
Yes. Never been to Europe.
Never been to Europe.
I have 1% European Jewish DNA.
And 1% Jewish DNA, is that what you said?
Yes.
Okay, all right. All right, the truth and a lie. Carla is from Honduras. She's never been to Europe, and she has 1% Jewish heritage based on, is this from 23andMe, Carla?
Yes.
Okay. I mean, not to out you or anything, not to say that that's not the lie. I mean, okay, never been to Europe, never been to Europe. I'm going to guess that you are from somewhere, but not Honduras. But most people are saying that you have never been to Europe. So Carla, why don't you tell us what the lie is?
The lie is never been to Europe.
Ah, winner, winner. All right, awesome. What part of Honduras are you from?
San Pedro Sula, which is in the coast.
Awesome, very cool. That's great. All right, thanks so much, and also help me keep track of who we've called on so I don't go back to people. All right, I think we are going Gloria, right?
Okay, my 3 statements are: I love to go fishing. I have 6 beautiful grandchildren. And the biggest fish I ever caught was a 20-pound catfish.
Okay, which one of those is not a correct statement? So say them one more time, Gloria. Yeah.
I have 6 beautiful grandchildren. I love to go fishing, and the biggest fish I caught is a 20-pound catfish.
Okay.
Okay. So Laura's right. I only have 4 beautiful grandkids. The other 2 are ugly. No, not really. I just have 4 grandkids.
Oh, that's fun. Well, congratulations. Do they all live close by?
They live within 100 miles from me. So yeah, it's not too bad.
Nice. And a 20-pound catfish, huh?
Yep.
Wow. Nice. If you have pictures later, we'd love to see it as well. So this is great. All right. Well, we'll get to see them. That will, maybe we come back from break, we'll have you load them if you can show us. Okay, this is a lot of fun. Well, thanks everybody. Elsa and I were trying to think, given the whole situation with COVID and everything, how do we make this a little more interactive today? So thanks for playing along. Okay, so we are going to talk about the GI anatomy. This actually makes, for those of you who are joining, thinking about how do you read and understand pathology reports and endoscopy reports, knowing the GI anatomy is critical. A number of those reports will share where in the body the scope was moved, where there were biopsies taken, if there was any abnormalities, if polyps were removed. So this is really kind of your guide map to what they're talking about in those GI reports. So I'm going to just start talking and then talking a little, and we're going to start with down by the rectum. And so you'll notice that the anus is really, of course, the outer extension of the bowel. And then the rectum is that cavity between, that vault between where the anus and then where the actual bowel begins. So the rectum is there. And so colon and rectum are two different organs, but they're enough biologically similar that colorectal cancer is considered one type of disease, but they are different organs. Anal cancer is different. And one of the things, we don't concentrate a lot on anal cancer, but it is a thing. I think it's something we should probably do a little more information about, but a lot of times anal cancer is biologically different enough that it is its own disease category. So anal cancers can be quite rough in terms of really thinking about the anal sphincter and what it means for just general evacuation of feces and the like. But right now we focus on colon and, or we talk about the rectum and the colon for our purposes. But for anatomy, the anus is definitely right there. So as you move up from the rectum, you come into the sigmoid colon. And so how many people know the term sigmoidoscope? I'm guessing there are some hands raised. If you want to raise your hand if you've heard of a sigmoidoscope. Currently a sigmoidoscopy is something that's still in recommendation. And that really is actually basically the lower third of the bowel. And so when you see the sigmoid colon, that is an area. There's a lot of focus on the sigmoid colon because a lot of different cancers can definitely be found in that specific area. And there's a concentration enough that if for some reason people can't or won't tolerate a colonoscopy, that there's enough disease in this area sometimes to still substantiate the need for that type of an exam. A sigmoid colon, a sigmoidoscope oftentimes does not actually require sedation to the degree that a colonoscopy, but it does still require a cleanse. But let's continue further into the descending colon. So again, on that left side, as we move up, and then where we start to see that move forward, the transverse colon. So that juncture right there, you'll know that that lays right below the stomach and into that area. And then as we go into the ascending colon, that goes on to the right side. And then we go into the basically the ileocecum and the cecum and the ileocecal valve. So for all intents and purposes, this is what we concentrate. The colon, as you all know, is actually a very long organ. If it's over several, I can't even remember how long it is, but if you struck out from linear, it's a very large organ. There's a lot of nooks and crannies. There's a lot of mucus. There's a lot that happens here because it really is the spot where we're looking at digestion and where a lot of the actual retrieval and evacuation of things that have been processed through food and energy sources are removed. So this is what we consider the GI area in terms of the large bowel. This is the colon rectum area that we refer to for colorectal cancer. And this is going to be something that's super important again, because when you read those endoscopy reports, it's going to let you know how far the scope went in, where it went in, and again, where they've done biopsies or anything is found. So becoming familiar with this GI anatomy is going to be critical. I would urge all of you, and these are things we could pass on, that if you're responsible for retrieving information, which most of you are, of course, for the reporting, have a picture of the GI anatomy in front of you so you can always get a glimpse of what's going on when you get those endoscopy and pathology reports back. What I want to say is for every single person who has a sigmoid colon done or has a colonoscopy done, you will always have an endoscopy report. That means that the actual exam has happened. You will only get a pathology report if something is removed other than the scope. So if there is a biopsy, if there's a tissue sample, that will generate a pathology report. But every single person will have an endoscopy report, even if there's nothing to be found. So just as a reminder, this is really important as we talk about those reports. So let me just stop here. Elsa, anything? I think we have a little bit of a poll here. So is the small intestine bowel examined also during the CRC screening? So we've talked about the large bowel. Do you do anything with the small bowel? Yes or no? We'll give just a minute. Okay, Elsa, what are we looking like? Yes and no. What about 50-50? This is a really good thing. So if we're looking right now, the littles in the middle right here, that is considered the small bowel. For colorectal cancer screening, we do not utilize and we do not actually examine the small bowel. This is largely kind of a small gelatinous type issue, and there's really, that would be really hard to do that. And so at this point, we do not actually utilize any of the small bowel for colorectal cancer screening. But what I want to say is for GI in general, that does include from basically the esophagus to the stomach, down to the small bowel, large bowel, rectum, and down. That's the entire GI unit. There are upper endoscopy, lower endoscopy is usually the large bowel, but the small bowel typically does not have any sort of formal advantage for screening at this time. So when anyone talks about colorectal cancer screening, we are talking about the colon or the large intestine, large bowel. Okay, good to review this work. Okay, next slide. So what I want to talk about here is actually colorectal cancer is preventable, treatable, and beatable. So if you follow the Prevent Cancer Foundation, this is their slogan. You can find precancerous growth called polyps, which can be removed. So if you look on the left-hand side, you're starting to see these sort of low rise and types of growths that happen coming from the polyp or from the lining of the colon. So what you're thinking here on the bottom as these bumps are starting to occur, this is basically the inside of that colon that you're looking at. So also if you go back real quick. So that GI bowel right there, those bowel, and this would be basically what's happening on the inside. So next slide. So if you look at that, that's the flat on the inside, what's going on. If everything is smooth and fine, typically there can be a little bleeding on occasion. There can be other types of dysplasia, which means changing in cells. But if things start to really become dysplasic and cells start to become like grow a little erratically, that's when these bumps start to happen. What's interesting is that there are types of polyps that grow that do not have anything wrong. They're just kind of funky little cells that are kind of causing little like growths on your skin. But what you'll notice is as things start to become bigger, the chances of them becoming either precancerous or cancerous become actually like really, really increase the chances. So if you hear basically asymptomatic or you hear like dysplasic cells, but when you start to hear adenoma or advanced adenoma, that's when we start to see those these larger polyps growing. And then even if you see that line, it's ultimately the bigger it gets, the more that it starts to grow. And then even eat into that side of the wall, which becomes invasive. That's when it really becomes cancerous. So Elsa, take that line away really quickly. Does anybody know why we have a colonoscopy every 10 to 15 years? And I'll give you a hint. What Elsa just showed is a big thing. Anybody want to come off mute and say, if we know this progression, right? This is something that can happen over time. This sometimes can happen, but why do you think we have colonoscopy every 10 to 15 years? Can I get a taker?
Hi, this is Julie.
Julie, tell us.
It takes that much time for it to develop so that you can actually see it.
Absolutely, exactly. Carla and Julie, you guys got that right. Bring that back, Elsa. It takes about 10 to 15 years that if this tiny little bump were to become something other than, just kind of a measly little abnormal asymptomatic polyp type work, or, basically, can't think of the name today. Sorry about that, guys. But if we see adenomas grow that would become a cancer, that would take 10 or 15 years. So that's why a colonoscopy is every 10 years. They go conservative because it takes anywhere from 10 to 15 years for this cycle to happen. That's happening on the inside of the colon. The bad thing is that when it starts to bleed, it's usually where we see this on this kind of on the stalk. and the like. And so sometimes the chances of it becoming, being a cancer is more when it's actually advanced. And so that's why colonoscopy is a great thing, is because if you come in, you can come in and you can remove this early before it starts bleeding or starts to grow. But there are some great advantages now, especially with the stool-based testing around what they're able to pick up as well. So, oh, yep, pedunculated polyp, that's exactly it. If it's growing on a stalk, it's oftentimes considered a pedunculated. And if it's actually laying on the flat, that is a completely different type of kind of growth pattern. But the chances of them being cancerous or being non-cancerous sometimes doesn't have anything to do if it has a stalk or not. You can even have some high risk ones that don't necessarily come up on the stalk, but just grow larger and larger and then come into the cell wall. So these are things that we must know. What's going to be making a difference is in the endoscopy report. They will actually tell you, so going back to that slide before, they will tell you what region of the bowel they saw one of these things happening or growing. Yep, so they will say ultimately 3 centimeter polyp found at the descending colon. So that's where it's at. And then most of the time, if it's that large or larger, they'll go ahead and remove that. So there will be an endoscopy and a pathology report. Next slide. So this is a big deal, everybody, name of the game. So average risk population, those are typically people who have a personal history of colorectal cancer, a personal or a family history of colorectal cancer, who have inflammatory bowel disease, and ultimately ulcerative colitis or confirmed or suspected hereditary cancers. So average risk doesn't necessarily always mean asymptomatic. There can be people who are average risk who start having symptoms. Symptoms will put you in a higher classification if you have them, but there's oftentimes average risk individuals that if they don't have any signs and symptoms, that doesn't really, it's really based on what's going on with their personal and family history. Basically, if they start showing signs and symptoms, they are no longer average risk. They will not use average risk modalities. They go straight to colonoscopy. But risk is really if a person has themselves had colorectal cancer, or they have a first degree relative, particularly, so mom, dad, sister, brother, or again, if they have ulcerative colitis, Crohn's disease, inflammatory bowel disease, or a type of situation called Lynch syndrome, which again, part of the reason that we're really looking at Lynch in the hereditary systems is that if you have a chance of having colorectal cancer with one of these syndromes, it can be upwards of 80% in your lifetime. So average risk, that's who we're talking about, is basically average risk population are people, actually, Elsa, this should be increased risk, right?
Average risk, meaning people who do not have any of these.
Right, exactly. So
yeah.
People who do not have these, yes. So sorry, that slide. So if you do not have these sort of things, so if you are average risk, that means that you have no family history, you have no personal history, you have a hereditary disease, or you're confirmed having those. So this means that you are at increased risk or high risk individuals, meaning that you would go straight to colonoscopy. But the great thing is that if you're average risk, which we talked about at the very beginning, are individuals who have no family history, who have no signs and symptoms, and don't have hereditary or genetic syndromes. Those individuals are really eligible for a variety of testing kits, whereas in this one, or a group who are increased or high risk, and they would ultimately go to colonoscopy. So let me just stop there and see if we have any questions or thoughts from individuals. Anybody questions? Okay. All right, let's go to the next slide.
Sorry, I have a question. This is Laura.
Yes.
What if they don't have colorectal cancer history, but they have other cancer history?
That is a good question. So Laura, one of the things that we are doing right now with CCSP, there can be individuals that might need to have screening started earlier, and we're going to talk about that a little bit later in the show. It might have a change in their screening recommendation if they have Lynch syndrome. So if they've had uterine, kidney cancer, certain types of cancer, and there's something going on in their family, that there is a Lynch or another hereditary situation, that will definitely bring them up to maybe being screened earlier.
Thank you.
Yep, and we'll talk about that too. Yep, okay. But the other thing I would just want to mention is the risk stratification isn't just if someone has had colorectal cancer. If someone has a family history of adenomatous polyps, then they should start screening earlier as well. So we'll update this slide a little bit too. So if Laura, so for instance, you know, in the situation where if my mom at 40 years old would have had adenomatous polyps, advanced adenomatous polyps, I would have started screening at 30 years old. My mom actually had colorectal cancer at age 41, so I actually started screening for colorectal cancer in my early 30s. So those are the things that we have to remember, that family history does make a difference in terms of when, and that's something that we'll work on this year, is making sure that it's really clear, especially with the new guidelines about when people should be screening. Those recommendations haven't basically changed at all, but the population and the average risk screening population has. So for average risk, so what we know right now is average risk screening is from 45 to 75. This has been adapted from the American Cancer Society as well as from the U.S. Preventive Services Task Force. At current, they're still at 50 years old, but Elsa, I think this is set to change in the next, at the top of the calendar year. Is that correct?
So they have about 1 year from when the recommendation was fully put into effect, which happened this spring. So by late spring 2022, all insurance payers should be following these guidelines, but some have already adopted. So it just depends on the particular insurance payer at this point.
Okie doke. So I'd love to know in the chat as I'm continuing to talk, how many people have already started changing messaging to 45? Are you starting to talk with your teams about 45? So if you can write and let me know how that's happening, that would be great. So CCSP, we will definitely follow the ACS guidelines or USPSTF, but for Medicaid, Medicare, and most private insurers, they follow the USPSTF guidelines. So it's coming, it's coming, it's coming. It will help mortality rates. So we're excited about that moving ahead. Next slide. So again, for those people who are at increased and high risk individuals, that family or personal history of GI disease, or people who have a first degree family member of colorectal cancer or adenomatous polyps, either you should begin screening for those individuals 10 years before or at age 40, whatever comes first. So in the situation where I'm with my family, someone is diagnosed, let's say at 60 years old, then screening should begin at age 40. But if my mom, again, when she was diagnosed, when she was 41, I started screening as early as 31. So it's really important just to make sure we understand people's family history. If they have a family history for your purposes, make sure and document the family history, which relative, talk to their providers about what that means so that you can make that referral. Preventive services screening is covered for risk for those who have family history. That should be covered under the ACA and prevention. However, if individuals are symptomatic before being 45 in the future, 50 now, that's typically something that's requiring an out-of-pocket cost. So that's something that's difficult. So screening risk for those who are at increased or high risk must be done using a colonoscopy, like we said. You may not be able to use the stool-based testing for those if there are signs and symptoms or if they're beyond an average risk population. So the Multi-Services Task Force, as well as NCCN, have surveillance and screening guidelines as well. I just heard yesterday that I think the Multi-Society Task Group is also going to be changing their guidelines from 50 to 45. So all the major groups will be doing that soon. But in terms of understanding that surveillance, that if there's something that happens, such as polyps or a cancer or how frequently, that's going to be dictated largely by the GI group, but they're going to follow those recommendations. So we will definitely be keeping you all aware. But again, the big thing to know is if you speak with patients, if they themselves have had colorectal cancer, you might need to be screening them well before 50 or 45 years old. If they have a family history who've had adenomatous polyps or colorectal cancer, they might need to be screened well before 45 or 50. Laura, to your point, if there's multiple cancers, it's something that they might need to have a visit about genetic counseling, genetic testing to understand if they're changing their guidelines sooner. And all individuals who have signs and symptoms need to automatically go to screening for a colonoscopy and will not be able to use any of the other stool-based testing as their first line. So Elsa, anything else to say about this, or do we have any polls right now?
I don't think we have anything else at this moment. Julie did have just one clarifying question of when all insurance types will start implementing the 45 age guidelines. So just as a reminder for that, right now, insurance payers are in the process of adopting that new 45 guideline. And so it does depend on that particular insurance type at the moment, but they have until 1 year. So the guideline was passed in May, so they have up until next May to implement that. Many do it on the new plan year. So there are several insurance payers, especially private insurance payers, that have already adopted the age 45 guideline, but there are some that have not yet implemented, but all will be doing so by next spring. Anything else? And definitely feel free to reach out to myself or Andy if you all have any questions that come up around your patients and risk level or those guidelines and also those age starting points as well.
Okay, awesome. Okay, so let's talk a little bit about the exams. So oftentimes you hear about the different types of screening modalities. So I know I've been talking a lot about stool-based testing. We'll talk about what those are. But in terms of the screening modalities that come up, which are types of exams that visualize the inside of the colon or what's going on there, those are oftentimes called structured exam, visual exams. But those basically are the colonoscopy, sigmoidoscopy, virtual colonoscopy, and those are all part of what's recommended from USPSTF as well as American Cancer Society. So the great thing is for colorectal cancer screening, there's a lot of different modalities. So we're going to talk about those that are approved. Colonoscopy, you know, and most of you know and have been involved. It's a scope that's about the size of your pinky. It moves with a lighted camera, and there's a spot in the center that can basically have clips or even kind of lassoing looking things that can come into the bowel. The great thing is that you can visualize the entire colon. It's really kind of a faster pace exam when you come in through the anus, rectum, sigmoidoscopy transcending all through ascending to the cecum and the like. Where it takes some time is pulling out, where they can take the camera and retroflex and move it all around to see what's going on. So on the way in, it's like just getting a lay of the land, making sure that there's nothing that they see that's a really big red flag. But pulling that out is really what spends the time to make sure there's washing opportunities, there's a light that comes up onto a screen, they can see what's going on. The sigmoidoscopy is also an internal exam where we go to the rectum and again to that sigmoid. So that sigmoid part of the colon, it's a sigmoidoscope. It's completed about every 5 years, whereas that colonoscopy, if nothing's found, happens every 10 years. So these are still recommended. Virtual colonoscopy is also recommended where they're using images of the colon. So they're using a CT machine and basically doing x-rays of sort all the way down the colon to be able to get a 3D model of what's going on. So we can reimburse for any of these that are navigated into visual exams because they are on the list of approved screening modalities. If you navigate a patient into any of these based on the screening recommendation, that is something that the program can do. But let me ask you guys all right now, if a patient is high risk or increased risk or has signs and symptoms, in the chat, write which one of these they need to have, or if they can have all of them. So write this down really quickly. If you're increased or high risk or have signs and symptoms, which of these types of exams is it appropriate to have? Going once, going twice, and I can't even see all my chats here. Colonoscopy, colonoscopy. Oh my gosh, we're winning, we're winning, we're winning. That's exactly right. The thing about all of these is if a sigmoidoscope, something comes back, virtual colonoscopy, every one of these things, a person will have to have a follow-up colonoscopy. But if they're high or increased risk, no need to do stool DNA, no need to do any of these types of exam. Winner, winner, chicken dinner, that's where colonoscopy fits. Okay, next slide. Okay, so stool-based testing. We're really excited because the market is booming. There's already been strong data over the last 20 years that FIT and FOBT testing, and it's getting more sensitive all the time, can show a decrease in mortality if used every year annually for 3 to 5 years, can reduce mortality by up to 30%. So the adage is the best screening test is the one that gets done. Not everyone can or will do a colonoscopy. Colonoscopy will not always be available for all people. Not even all insurance plans will start covering colonoscopy as the first test for average risk individuals. So right now there's the guaiac-based fecal GFOBT. There's also the FIT test, which is the immunochemical test that are largely available. They're cheap. They're easy to implement. The devil's in the details. It's making sure that you do something annually. So it's whether it's with a clinic for a flu fit campaign, whether it's a dental exam, whether it's coming in on the birthday. The difficulty of these tests is just making sure you get them in the hands and returned from individuals every year. If you do this once, it's a one and done. There's no data to show that doing this one time makes any difference in incidence or mortality. If you're going to do a FIT FOBT program, it has to be every single year. That's where we're going to be doing some more capacity building and then making sure to get those completed tests. And again, write it in the chat. What happens if someone has a positive FIT FOBT test? Write it in the chat. Where do they go next? That's right. If I'm starting to see, it's going to be a C word. It's very, oh, there we go. There we go. Colonoscopy is lighting up the stage. That's exactly right. So the thing is, it's a good test. It's definitely the best test is the one that gets done and gets done well. Every 3 to 5 years, every year it needs to happen for at least 5 years to show any benefit for the FIT FOBT. Enter Cologuard, dun, dun, dun. So the FIT and FOBT largely look at irregularities in changes with detecting blood in human blood. About 15 years ago, FIT and FOBT looked for any type of blood. So if you ate a big fat juicy steak the night before, it would detect cattle blood, whereas now FIT FOBT looks at even the type of hemoglobin specific for human. So that test in and of themselves got even more specific. They're even better than they were, but Cologuard actually is a stool-based test similar to FIT and FOBT, where half of the test is a FIT and FOBT that looks for that hemoglobin. The other part of the test actually looks for cellular changes that are sloughed off with changes in DNA. So anytime they're, that they see this sort of shed and this happen, which can really come up into the in the stool, that these sort of things really are detected. That test not only picks up the blood, but anything that's being sloughed off. So when we went back to that adenocarcinoma sequence where we showed the growth of polyps every 10 or 15 years, this Cologuard test will actually pick up those cellular changes when they start to get a little wacky, even well before they start to bleed. So that's the advantage. The other sort of winner chicken dinner part about stool DNA and Cologuard is that the test actually has to be every 3 to 5 years versus every single year. So again, for those of you who've done health fairs, who do population management, the aptitude of getting someone to do something every 3 to 5 years versus annually, that's an advantage. But again, colonoscopy is only every 10 years if everything is normal. So thinking about which test is best for which person, knowing their behavior, adherence, other health issues, those are things to consider. So again, should you have, let me say, as Elsa said here at the bottom, I was going to try to change this into some sort of fun thing we could do, but stool-based tests are only approved for those who are individuals at average risk. So let me ask this. If someone is average risk, but showing up with blood in the stool, 10 pounds weight loss, and change in their stools, in addition to the blood, should they use a stool-based test? Write it in the chat, write it in the chat. No. Actually, that's exactly it. Okay, so stool-based tests. But what I do want to say about these tests, they are great. They do great things for a number of people. Not everyone will or can have a colonoscopy. The other thing that's going to be coming on the market, they're going to be blood tests, urine tests. But at the end of the day, if something is found to be positive and a need for follow-up, colonoscopy is going to have to come into bear. Okay, Elsa, anything else to say about this?
I think that's everything, and we're really excited this year to be hearing a little bit more about what you all are doing for stool-based testing programs, work you're already doing, and we're here to help support with capacity building, knowing that these types of tests have been really helpful for increasing access to screening, especially during COVID and beyond, but especially during COVID, seeing an uptick in these types of tests because they're easy to administer. So that's part of the grant this year, is providing support for these tests, as well as continued reimbursement and support for navigation into the visual exams. And we know that most clinics are utilizing colonoscopy when they're thinking of visual exams. So in general, we are saying colonoscopy is that fee for service reimbursement. But as Andy hit on before, occasionally there is a provider who will want to do a sigmoidoscopy or a virtual colonoscopy, and we are able to reimburse for those as well. But knowing that most are using colonoscopy, we're generally saying colonoscopy.
Okie dokie. All right, awesome. Let's move on to the bowel preparation. So right now, in terms of the bowel prep, that we do know that ultimately for CT colonography, for FlexSig and colonoscopy, you're going to have to prepare the bowel so that way when the scopes are inserted or when the pictures are taken, that we aren't full of bowel movement or other issues in mucus and whatever that might really obstruct the vision. So ultimately bowel preparation is critical, and it's one of the biggest part of where patient navigators make an impact in terms of being able to see the colon, find the anatomical views, but also find polyps, as well as places that are bleeding or what have you. It means restriction in diet, fluid restriction, in terms of anything that's colored, and making sure that we use a type of preparation that gets the bowel all set and ready to go in terms of being able to make sure the secretions and all of the waste is moved away. So bowel preparation, one of the biggest parts of what CCSP navigators need to know about. A tip from one of our partners is having the prep available physically to show individuals and patients and understanding the type of bowel prep that's used really at the time that you're educating people, talking about the bowel prep, having the preparation sheets, showing even if it's a sample of the type of bowel prep that they'll be provided, demonstrating anything you can really improves the adherence of patients actually utilizing the bowel preparation. Also knowing when they need to stop eating solid foods, when they need to start to go with clear liquids, and then what they can expect, in terms of symptomatology during that preparation. So people sometimes will feel like they have the tummy flu a little bit, they can feel bloated, letting them know that it's normal. Is something that's really going to be quite helpful for them, so they don't feel like something's wrong. So we've really broken this down into thinking about what people need to consider before the colonoscopy, a week, a couple days before, and then the day of. So one of the things that we really want to make sure that navigators working with their GI teams, and it's really important to understand who does what, call to remind the patient about the exam that's coming the week before. Making sure that if there's been any indication of using anything like a Coumadin, any sort of a Levinox, any blood thinners, that if for some reason that has not come up, that the patient, the GI group needs to know. So if they're stopping any medications or needing to change things up, they're really clear on what that looks like for them. The navigator can really help make sure the primary care and GI doc know what's going on with those patients. And if the patient needs to stop any of those meds, they can be a liaison in helping message. How bowel preparation solution at home and reading through those instructions. So one of the things we want to try to make sure is that people aren't, just hours before the colonoscopy trying to buy the right food, trying to buy the right the bowel prep, that it's really starting this a week before, because if it's just happening the day of, then it's not going to work. So making sure people understand about what clear liquids are, having, knowing that they should be eating, soups and things that are clear, really getting ready to go and prepare the week before. A couple days before, people need to be eating lightly, avoiding bulky and fibrous foods. That big fat juicy steak that I mentioned, probably not a good idea. Drinking plenty of water. And then the day before, we need to make sure, probably the day before the colonoscopy starts, a navigator's calling them to remind them clear liquid diets, but no red, blue, purple liquid that will maybe mimic blood looking type solution that would be used in the bowel. So only water, clear broth, clear fruit juices, coffee that has no tea, has no cream or anything that's going to cloud it, plain gelatin, popsicles, and sports drinks. Those are the name of the game. So even giving people a shopping list a week ahead can be great. Making sure that that navigator calls the day before, plan, follow through, using straws, understanding what's going on, refrigerating, hydrate, entertainment, soft wipes. These are the things for a colonoscopy in terms of getting people ready to go. We can make sure and really try to provide you guys all of these types of things, so that way you can help patients really get ready to rock. But if you think about that time course of when you provide those calls, information, materials, it's great. But remember, a reminder for them to plan, to follow those instructions. We're getting input that refrigerating the bowel prep or using a straw can help with consumption. Staying close to a bathroom, maybe not inviting, all your friends and family to stay the night over. If you're going to need to use in the bathroom, it's really smelly, but making sure to stay hydrated with those clear liquids. Finding ways to be comfortable. So, distract yourself with some good Netflix or some good books. And then, of course, just knowing that you're going to be using the bathroom a lot. So soft wipes, sometimes different types of butt paste of sort for those who have kiddos, anything that can cause some decreased irritation. We want to try to make it as comfortable as it can be, but also, again, being very forthright with the patient about what the experience is going to look like. So trying warm compresses on your lower on the back and tummy can also relieve discomfort. So, and I would say for all of you who haven't had the opportunity, if you have a chance to work with a GI provider, or you can let Elsa and myself know eventually once COVID restrictions, then we can help you observe a colonoscopy, even taking a little bit of a taste of a prep, of a bowel prep, to just get a sense what patients are going through. Or even if you have your own tips and tricks about what's worked and what hasn't worked, that can be really helpful for patients as long as it's in accordance. So we're going to stop here. And I think also we want to hear from everyone about what are their tried and true bowel tips or bowel prep tips, or what materials they've used that have been helpful.
Yes, so feel free to either put that in the chat, or if you want to share something and come off mute, we'd love to hear, for some of you, especially who've been doing this for a long time, what has really been helpful for your patients and for providing navigation for them so that they really feel prepared and comfortable with the bowel prep. Anybody? Is there any visuals, brochures, or just different analogies or different information that you've told them that's been really helpful? Keeping the prep cold. Anything else? Is there any particular drinks that patients have found is really helpful and that they enjoy when they're having to drink that prep? So drinking it cold has worked for a number of people, and the straws. And yes, we've shared some of those visuals of the different types of drinks that they can buy, making sure it's clear on the colors. So that visualization, clear Gatorade, using a lemonade mix, mixing it directly with Gatorade, knowing that belly discomfort is normal. So making sure they know what symptoms they might experience. And unfortunately, can't drink alcohol even if it's clear. All right, these are all really great tips, and we'd love to continue to hear what's worked for you. And even if you have an infographic or different visualization that has really worked for your patients and you'd like to share, please do so, and then we can share it with other navigators and teams as well. And just got a great resource from Carla, which is colonoscopy preparation instructions from Kaiser, and including offering it in different languages. So thanks so much, Carla. All right, moving on. And I'll turn it back to Andy.
All right. So one of the things that I want to just talk about is what's the best bowel prep type. And I will just say this, that these are some of the types of bowel prep that are available. Talks about the costs, advantages, disadvantages. What I would tell all of you is that your GI practices know what they like to use and how they like to use it. These are the ones that are largely available and utilized at this time. Make sure that if you're a new navigator and you are not clear on what the GI instructions are, you have a copy of those, you know what your GI guy uses, guy or girl, making sure to know that also be really clear about what they're doing and what you're doing. So if a patient gets 3 calls in the same day, one from you and 2 from the other side, that might be a little annoying. So just make sure you're really clear about who's visiting with the patient, about dispensement of the bowel prep, the instructions, what you're doing, what they're doing from the GI office. But again, sometimes a call from home base, which would be all you from navigators from your clinic system, is really kind of, I think, reassuring for patients about hearing from their own health team as well. So know what they're using, but it's definitely, good for you to have a sense of like what's happening. What I will say is sometimes you can have different providers and different groups who use different bowel preps. So just again, being really clear on what the patient, either if you're dispensing, you're helping dispense or educate, make sure that you're really clear about what that looks like. Okay, next slide. Split dosing now is becoming standard of care. This is one thing I do want to mention. We are starting to see trends, and I think there's more and more data to show that sometimes if people do part of the bowel prep between 6 to 9 and then stop and then start again, like 4 to 6 hours before the procedure, that sometimes rather than drinking all the PEG solution or all of the sort of fluid at one time, there's new data to say if you start, spill it out, clean it out, let it sit for a minute, let mucus and everything else, let the stuff continue to filter and then wash again, that actually might be better than actually just doing all of the solution at one time. So I just want to say better quality colonoscopies coming out, patients are showing better satisfaction, adherence, and then this really allows for same day preps for the afternoon procedures. So sometimes people aren't using that, having to do the whole day before prep, they're able to sometimes use it on that same day. So that's a little less time away from work, kids, just sort of what's making them tick. So use of laxative along the prep, yes, that's exactly it. So a lot of times of those biscotal tablets, even with the bowel prep, there's oftentimes solution as well as a laxative. It can look a little different, but I just want to say that if you aren't seeing standard split dosing, that's something that would probably come up moving ahead. We definitely try to make sure the GI docs, they know the trade. This is what they do. They know best. But I think sometimes advocating for patients, and this is something that if patients are adhering more so to, and if you're seeing a patient having some difficulty, talking to your primary care, your medical leadership about, how prep is happening with your GI provider, that's something that might come to bear. But I did want to mention that that's ultimately one of the big things that are coming forward. So next slide. So picking a safe prep, again, there are certain indications where people may or may not have issues related to renal failure, cardiac, and what have you. This is also an area where you are all going to be coming super in handy. So if you know a patient has a comorbidity and they're having certain medications, any issues related to, again, that renal failure, liver, cardiac issues, they have certain types of medication, it is really important that you make sure that patient shares that with the primary care doc or the GI team so that they're really clear on which type of prep is probably the best for the patient. So the patient needs, the MD needs. We also have a nurse who's a GI guru who does a really strong presentation, and we've stole some part of her slides, but we'll have her on to share some more about bowel prep and how to like do it well and what you should know in further detail. But these are some of the things, again, if you notice that a patient is on a blood thinner, you know, the colonoscopy and having a colonoscopy while they're on a blood thinner can have bad ramifications if there's a perforation. It'll cause hemorrhaging, a bleed out. Also with bowel preparation, because the way that that works with a saline solution and kind of an osmosis types of approach, if people have cardiac or liver or other issues, a certain types of bowel prep might not be right for them. So it is critical that if you pick these things up or hear these things, you make sure that the primary care doc or the GI doc is well aware. Okay, next slide. So we are now going to turn it over to Elsa. You're talking about this part, right? Okay, good, because I've been talking for a while. But before we go to capacity building around the things that we've talked about, I'm feeling the urge for 2 truths and a lie. So everybody get your papers out. You know your 3 statements. So let's go with Cindy and Victoria. So Cindy, we're going to start with you. Your 3 statements, one of those which is not true, the other that are true. And then Victoria, you will go right after Cindy. So Cindy, are you ready?
And Cindy, I know we were having a little trouble hearing you before, so not sure if you're joining by phone, but if you are, you could press *6 to come off mute or put it in the chat. Not hearing you yet.
Can you hear me now?
Yes, ma'am.
Okay. So I didn't think you guys were ever going to hear me. So I have never been out of the States. I raise cattle and I like to hunt.
Awesome. Can you say that one more time for everyone?
I've never been out of the States, United States. I like to hunt and I raise cattle.
Oh my gosh, I think you are pegged, Cindy. So people are voting that you've never been out of the US. Is that correct?
That is correct.
All right. Have you been to, but you do like to hunt and you do raise cattle, huh?
Yes.
Nice. Very cool. And you're in Uncompahgre, so in the western part of the state. So very cool.
Yes.
Very good. Thanks for joining today.
Yes.
All right, great.
Thank
Let's go with Victoria.
Hi, okay, so I have 5 sisters. I love to fish, and I have 2 grandbabies.
Oh, wow. This one's coming in. You're all over the board. Love to fish, no fishing, 5 sisters, grandbabies, 5 sisters, 2 grandkids, grandbabies. Wow, we've got a mixed bag here.
Okay. Well, I'm going to say not fishing. I do not fish.
Okay.
Really, and my grandbabies are actually grandpups.
Very nice.
2 grandpups.
Grandpups, very cool. Awesome. Very nice. All right. Well, thanks so much for joining. So thanks, Cindy and Victoria, for being good sports. So thanks everybody for doing this. We hope it breaks up things a little bit. So, okay, Elsa, I'll pass it back to you.
Thank you. And we're almost at a break. So just this section and then we get our break. So just hang in there for a few more minutes. But did want to touch a little bit more on those components around capacity building that are beyond just colorectal cancer screening, especially for colonoscopy that we're focusing on in these next 2 years of the grant, and already done a little work around the lung cancer screening and family history and genetic cancer risk screening with Brunner Caritas currently implementing the lung cancer screening, and Uncompahgre, Cindy's team implementing family history screening, utilizing a screening assessment and connections to genetic counseling and testing. So as Andy has hit on a little bit, if in our grant extension, we were able to revise our implementation plan a little bit, and we now have some funding to support clinics with building capacity for implementation of stool-based testing approaches on a population-based approach, lung cancer screening, as well as that family history and genetic cancer risk assessment piece. And so we're about to begin looking at your capacity and interest for each of these areas. So we'll be having our meetings one-on-one with your clinic systems in the next month, where we'll be doing a slight assessment real time about your interest and capacity for engaging in each of these areas. And then we'll be able to, for those that are interested, provide some technical assistance and resources to support implementation and referral processes and workflows. This doesn't mean that you have to do a full deep dive implementation like we did in those pilot projects, just really thinking how we can better support clinics with implementing those strategies, whether that means patient education, provider education about the guidelines, as well as some support for those workflows, whether that's referring out for some of those screenings or doing some more in-house implementation as well. So that's the name of the game, but much more to come when we have our one-on-one meetings. Really excited to support you, whether you're already doing this work or just starting to think at your clinic system about greater opportunity for these other preventive screenings. For lung cancer screening, a little bit of the why we're focusing on this. As we already mentioned, leading cause of cancer death in Colorado, and then a very common cancer diagnosis as well, although this is decreasing in Colorado as the smoking rate is going down. So the American Cancer Society did estimate, though, that in Colorado there would be over 2,500 new diagnoses and 1,290 deaths estimated for 2021. And with lung cancer screening, having the opportunity to catch it at earlier stages, and too many cases currently being diagnosed at late stage, the USPSTF did recommend the use of low-dose CT for screening for lung cancer, which was adopted in 2013, and they just updated their guidelines this past year as well, like was done for colon. And so about a quarter of cases were caught at an early stage between 2013 and 2017 in Colorado. And that's actually a good improvement and better than some other states, but there's still substantial work to be done. And even with lung cancer screening being implemented since 2013, uptake of the screening has been very low for the eligible population. So in Colorado, it's estimated about 3.3% of those who would be eligible were actually screened in 2019. And this is a little lower than the national rate of 5.7, but overall still very, very low when we're thinking about colorectal cancer screening, which has an average in the about 65%, 67% of eligible people are getting screened for colorectal cancer. And so there's a big need to improve these screening rates for lung cancer screening and really increase access for those that are at risk for better outcomes and catching lung cancer early. So we've been partnering with National Jewish, who've been helping with their lung cancer screening program, think about how we can better implement in primary care. And for the current guidelines for lung cancer screening, this was just updated in this spring. So these are currently being implemented as well as it was for the new guidelines with colorectal cancer screening, but the new guidelines are age 50 to 80, currently smoke or quit within the last 15 years, and a 20+ pack year smoking history. And I'll talk about how you calculate pack years in just a moment. But The new guidelines have already been adopted by Colorado Medicaid, and most private insurers. Medicare is still currently reviewing them, and they're following the previous guidelines at this time, which was 55 to 77 and 30 plus pack years. So with these expanded guidelines, there will be many more people who are now eligible for lung cancer screening. And one thing as a navigator can help people review for eligibility, understanding if they fit the eligibility criteria, helping with calculating pack years, which can be complicated if someone has been a smoker for many, many years, but they might have had some quit attempts and at some points smoked more or less in different years. So at a simple level, the pack years calculation is the number of years a person has smoked times the average number of packs they smoked per day. So for example, if they smoked for 20 years and they smoked for 2 packs a day, that's 40 cigarettes. So 20 years times 2 would be 40 pack years, which would fit that criteria. However, it can be complicated, as I mentioned. So there is this calculator that I linked that can help people look at their smoking history over time, if they've had different intervals, different pack years at different points in their life, putting that all together. And then also an important component of lung cancer screening is the shared decision making. So this is required to be completed with a licensed clinician. And so understanding what the person's risks are, as well as if they really feel like lung cancer screening is something they're willing to commit to, and also looking at other comorbidities. So that's something that has to happen for a referral to be made. And also smoking cessation counseling needs to be offered. However, a person does not have to stop smoking. Someone does not have to stop smoking. They can still be a current smoker to go through lung cancer screening, but just smoking cessation counseling and resources need to at least be offered to the patient. And of course, in that shared decision making, they'll be discussing whether a patient is willing and able to undergo the screening every year, as well as follow-up tests. And then clinicians will be able to actually get reimbursed for lung cancer screening. There's a specific CPT code for it, so different than a diagnostic CT or a chest x-ray. Lung cancer screening has its own specific process. And so the navigator can really help making sure people are eligible, making sure they go through that process and get to their CT, which doesn't often happen in primary care, might in some of those critical access hospitals, but often there's a referring partner as well. So just for a quick poll, seeing if anyone knows the answer, and I said this really briefly, but seeing if people know the answer for this one, is how often that lung cancer screening happens. So when someone gets screened, and if they don't need to come back earlier than the normal interval, how often is the lung cancer screening interval? How often should eligible individuals get screened for lung cancer? I said it really briefly, but just wanted to see at a baseline if people know the answer. So put in your best guess. Give it 15 or 10 more seconds. All right, I'm going to end the poll. So the correct answer, and a couple of you got this, is every 1 year. So lung cancer screening is an annual screen, just like a FIT or FOBT test. And so when a patient agrees to participate in lung cancer during the shared decision making, the provider should be making it really clear that this is an annual screen And then in terms of patient population management and patient tracking, needing to make sure that there's a system in place to send out reminders to the patient that they need to get this screening done every 1 year. If there is an abnormal result, a nodule, they might get called back in for earlier low-dose CT to monitor, or a different diagnostic test and workup. However, it is an annual screening as well. All right. So moving on, just to touch briefly as well on the genetic and family history screening. However, before I move on, I see a question. Yes. Yes.
So with regards to the number of cigarettes smoked in Colorado, what about, or in other states even, the use of cannabis? They smoke that. How does that affect this?
Yes, we've gotten this question, and this comes up in conversations with our experts in lung cancer screening quite often in Colorado. However, at this time, cannabis, marijuana is not part of lung cancer screening. And so knowing that that is a potential exposure, of course, and risk, there's still research happening around this area, but the lung cancer screening guidelines are based on the criteria from the National Lung Cancer Screening Trial, unfortunately, and so they did not consider cannabis use in that. And so currently, those individuals are not eligible for lung cancer screening under the guidelines. However, I will mention that many lung cancer screening centers and programs have an option for a self-pay for patients that either don't have insurance or don't quite meet the guidelines, but with a provider, there might be the possibility that some people still need to get looked at for lung cancer screening. So that's something that occasionally is an option, but right now not part of those guidelines.
Thank you.
And Laura, one of the things I'll say is I know that working with some of our partners in Colorado, and you might have seen this in the news, I think it was about a year and a half ago, there were some of the first confirmed deaths from lung cancer attributed to smoking or vaping marijuana or THC or products. So I think to Elsa's point, I think that's coming. It's not there yet, but I'm guessing with the amount of usage, especially in states like Colorado, we'll probably start to see that more and more. But even up until a little more than a year ago, they hadn't actually had confirmed deaths related to. So now that it's happening, I think we'll see it, but it's going to take a little bit before I think they make that. However, Elsa, I think you're right that some of the other guidelines might allow a little bit of flexibility. And I think if some providers feel that patients are using this sort of like ingestion of inhalation, they might ask providers and make those sort of referrals. But within that USPSTF and NCCN guidelines right now, it's just not written that way.
Yes, and yep. And so lung cancer screening for tobacco use and particularly cigarettes is covered by insurance. And so for any other reason at this time, not covered by insurance, but for those that are current or former smoker within the last 15 years and meet those criteria for lung cancer screening, it is covered by all insurances as a preventative screening that shouldn't have any copay. Okay, so just for the sake of time, I'm going to move on to genetics and family history. And with our work around this, we've been working with Uncompadre, and we're working with Denver Health for the last couple of years of the grant with implementing a family history cancer risk assessment and referral workflow for genetic testing and counseling. We've had some transitions in capacity and access to genetic counselors in Colorado. And as it Cindy knows, we've gone through a few different genetic counselors for the program, which has been a little bit tough for our clinic systems. But we now have a new partnership being set up with Ambry Genetics, which is really great because they are able to provide a chat bot for assessing family history cancer risk, as well as genetic counseling and testing for those that are eligible, and some in-kind support for those that aren't able, that don't have insurance that covers it, although working with insurance providers for those who do have insurance. But we're using these screenings based on the NCCN guidelines to identify individuals through the primary care setting who might benefit from genetic evaluation and counseling, and genetic testing based on their family history. And with that, for those with a family history and those that may have a genetic mutation, they may receive individualized, tailored screening and risk reduction guidelines depending on the cancer risk in their family. And so that has implications for our tool is really focusing on the NCCN guidelines that are most actionable for screening and medical management. So Lynch syndrome cancer, related cancers, including CRC, as well as breast, ovarian cancer, and Lynch syndrome has many different cancer types that are connected with it. So really focusing on, is there a large presence of cancer on one side of the family in many different individuals and close family members, even if it's more than one type of cancer, trying to capture that family history and provide connection to genetic counselors who can better evaluate that risk level and what the screening guidelines that person needs to have and follow. So I am going to pull up our next poll around family history screening and see what your knowledge is of family history of cancer before we go into our next slide. So this is, which of the following statements are true? Oh, and this one looks like it cut off, but it's people younger than age 50 with a family history of CRC or other cancers are not eligible for CCSP. All cancers are genetic. All cancers are hereditary. And people with a family history of cancer may need to be screened for colorectal cancer more frequently. Or are all of the above true or none of the above true? All right, we have about 8 responses, so I'm going to end. And most people got this one right. So the only one of these that is true is that people with a family history of cancer might need to be screened for cancer, including colorectal cancer, more frequently. And that really depends on that exact risk level and pattern within their family. And so identifying that family history is really important. And then having those people go on to genetic counseling, where the genetic counselor can determine their correct screening interval based on their risk. And those genetic counselors will be following the guidelines set by NCCN. All right. Great job, everyone. So not all cancers are hereditary or based on a risk in the family. So we're seeing in the research and the literature that about 70% of cancers are not due to a family history or genetic risk. And about 20 to 25% of cancers, we are seeing a pattern within the family more than one person in the family having a risk of cancer on one side of the family, and then 5 to 10% of cancers really being hereditary, meaning that the cancer is due to a genetic mutation that is inherited through the family. So some people might have a family history of cancer. I'm seeing that in more than one family member, but it may or may not be due to a genetic mutation. And there's many genetic mutations that we are still learning about. So every year when they do genetic testing, not every year, but very frequently, we're getting greater understanding of what those genetic mutations are that really have implications for cancer risk. And so our understanding of those genetic mutations that have an associated risk is increasing quite frequently. Okay, and so this is the family history screening tool that we have been using for the CCSP program, which is looking at a person's personal risk of cancer, as well as the prevalence of cancer in their first and second degree relatives, looking at their personal history, parental, brothers, sisters, half-brothers, half-sisters, children, grandparents, grandchildren, aunts, uncles, nieces, and nephews. So understanding if that person does or does not have cancer, these cancers in their family, and with that specific criteria of age. And for some of them, if it's outside of the particular body part, if it's metastatic or not, and looking at that particular side of the family. So this is the tool we've been using, and if there's a response of yes to any of these questions, that's when we've been prompted to have referrals on to genetic counseling, and those genetic counselors will look at genetic testing is right for those patients. But that's what we've been doing with Uncompadre and Denver Health, and now having the opportunity to further look at clinics' capacity to implement a tool like that, and using Ambry Genetics as well, which has a particular chatbot that can help people assess this risk beyond just a paper tool. So really, really excited about this opportunity going forward. And this is just a preview of what it looks like. So I'm going to see if Andy has anything else she'd like to share, but then we do have our break.
I think that I am overdue for a bio break, so I am not going to actually hold us any longer. Elsa, how long, when do you want us back? You are on mute.
Let's do a 5-minute break. So it is exactly 11:10 right now. We'll have everyone back at 11:15.
All right, awesome. See you guys back.
All right. Welcome back, everyone. Let's see if everyone's coming back right now. And we are ready to move on to our next section, which is patient navigation. So we have the patient navigation section, and then the much anticipated evaluation and reporting section. So we might go a little faster through this next section to leave plenty of time to go through the evaluation, reporting, and interpreting endoscopy and pathology reports. So let me see if Andy is back.
I am right here, Elsa.
Awesome.
All righty, so what's up?
Go ahead, I was gonna say, take it away.
Take it away, all right. So I just want to remind everyone, the role for navigators, particularly barrier reduction, access to care, really thinking about that enhancement and quality of delivery of service, and making sure patients have a really good experience with you, with the process, and really thinking about how this can oftentimes be a stepping stone for other preventive screening services. So that's really the name of the game. And then I think, of course, we want to just make sure that with the role of Navigator for CCSP, the navigators who are working with the patients really connect with patients, whether it's linguistic, culturally, really seeing themselves as sort of an advocate within the community. So barrier reduction, access to care, and really allowing the rest of the team to work at the top of the licensure. So nurses doing really the work of a skilled nursing providers, and then of course that navigator really connecting to the patient. So that's really the name of the game. Next slide. So when we think about what we're talking about for patient navigation, we talk about the in-reach outreach. We talk about identifying who's eligible for the different screening, educating patients about the types of exams, making sure even to understand the difference between, body parts. I'll never forget the time that we had someone on air talking about her colposcopy and how she was so excited that CCSP had helped, not realizing that it was a colonoscopy. And so thinking about anatomy, communication, education around patients being educated around the type of exams, procedures, and the medical jargon can be hard. So thinking about that, communication in with providers and patients, really thinking of that barrier reduction. So barrier reduction, assistance for transportation, the reminder calls that we've talked about. And really, if someone is diagnosed or up until that time of appointment, coordinating care. And then, of course, many of you are really working with the rest of your team to think about insurance coverage, data collection, and what have you. Those are the things that we really are interested in really thinking about. So next slide. So one of the things I've talked about, and I think I alluded to this, CCSP has a really nice form that's really thinking about what are the critical core areas of navigation, and then what are the role and function under those competencies. So I would say that if it's been a while, or if you're new to CCSP, sitting down and going step by step to think about who is doing what within the team. We are talking a lot about the barrier reduction, and the role of Navigator is helping increase patients' acceptability, ability for screening, whether that's education, that bowel preparation, talking about preventive screening, making sure with those reminders and appointments, but it really is a team-based care type of approach. So really sitting down and thinking about the step-by-step who's doing what, and then who's really taking charge of the holistic idea of coordinating care for the patient. We do have a single page step-by-step that a lot of times when we're in person, we have you all gather together and really fill this out as a team. And if you're unclear about who's doing what, the patient will be confused. The other thing is I've made some alluding, of course, to today about what is the GI unit. So getting in touch with the GI provider to understanding the type of bowel prep when they're making provider calls, who's going to follow up with the patient about the outcome of the screen, those types of things are going to be critical. So using this form can be very, very helpful for thinking about who's doing what and making sure that the navigation process is well established within, again, within your clinic system and working with your partners. And also, I believe that we've sent this out, or we will be sending this out for people to utilize, correct?
Yes, we generally send it out every year, and I'm going to send out all of the resources we talk about today after this training.
All right, awesome. All right, next slide. So we are going to breeze through these again, because I think most of you on the call are really interested in the endoscopy and provider pathology reports. But that in-reach we're talking about is understanding who's eligible. You currently have a patient panel. You currently have ways to identify who's eligible for different types of screening. Utilizing those types of opportunities, case huddles, or team huddles, identifying who's is being seen in a certain day, identifying the need and opportunity to talk to them about preventive screening and navigating them into care. That's something you can do that you already have established within your system. Those patients, many of them have not already been seen. We know from your UDS measures and others that there's still over half the population in most of the clinic systems that still are eligible for screening that have not been. But there's also the opportunity for outreach. So if you're doing health fairs, if you're doing campaigns with the TV or radio, and talking about the opportunity for prevention and awareness, bringing those folks into your clinic system so they can receive those care. That's part of what navigators can do in terms of helping really think that through with the rest of the team. And then really thinking about how do patients enter into preventive screening. So again, going through that checklist again and thinking about how you're going to work with patients to educate, to communicate, and to really get them into that preventive cycle is really part of the goal. All right, next slide. So again, InReach, part of the ways you can do that, your EMRs, EHR systems, looking at who's eligible for WWC or CICP. If you look at a list of women who've already been screened for breast and cervical, chances are, because they've done one preventive screening type of exam, they might be able to do another. And so giving them a jingle to say breast health is important and so is colorectal cancer screening. You know, can we get you in for an appointment? Hey, you know, I know that you and your husband are both over 45 or 50. Can we talk to you about getting in for colorectal cancer screening? These are the kind of things that you can do. So use the who's eligible for CICP, your EHR, identify. Even within your clinic system, you can spread awareness by the make it your own type program where you can do some outreach and awareness. This year, we'll have some ways and talk with you a little bit about how you can do outreach within your clinic and messaging. So those are some ways that you can post flyers or postcards or even do that kind of outreach, even with mailing, social events, posters. Those are things that we can bring and really help you move this forward. CCSP has budget for this. If you're interested in this, get in touch and let's think about how we can help you with a coordinated campaign. Next slide. So patient education topics, we know that of course, really understanding those guidelines, talking about the processes, screening intervals, these are all the things that we can do as well as healthy lifestyles. So really integrating that type of work in the discussion for outreach and inreach is also going to be super important as we move forward. As we start to talk about lung cancer and hereditary cancer, I think what we want to stop talking about is independent body parts and more preventive services in an integrative way. Next slide. So some common essentials, these are things that we're going to be really thinking about. We've offered many motivational interviewing, but how to meet patients with where they are, how you all have a set group of tools within the toolbox to thinking about how do you look at where people are in terms of their own health behavior, their own goals, and thinking about moving them through the process. One of the things I said about CCSP is although we have about 35,000 people that we've navigated, completed into screening, I'm guessing there's probably 100,000 that have actually still been thinking a little bit about making movement. And although they might not have done cancer screening straight away, they might have made other health decisions. So really thinking about how we're meeting people, you all as navigators thinking about MI approaches, understanding changes of stages of change, how you're communicating with patients, that's going to be critical. And those are areas that we will continue to help you grow with PNTC and other partners this next year. Next slide. Barrier reduction. One of the things that we talk about is, of course, the logistics side for transportation, elder care, assistance with time from off work, really thinking about how do we help patients remove that type of barrier, maybe thinking about scheduling bowel or their colonoscopy on a Monday so that they can bowel prep on a Sunday and not lose any time away from work. These are the types of things that we really want to consider when you're thinking about how to make it important for patients to really get in, but not make a lot of disruption in life, or sometimes it just won't happen. But we also know that culturally and from psychosocial components, there's a lot going on for people. So, and we want to make sure that the education materials, as well as everything that we're delivering, really thinks about language, thinks about culture, thinks about background and setting, because getting a colonoscopy in Lamar, Colorado, and talking with people about what that looks like and how that happens, or where in a rural area that you might have to travel, looks very different than having maybe someone who's in inner city Denver and what resources they do or don't have available. So context matters. And I think that's culturally some of the things we'd like to help with and want to be adaptive to the work that you guys all need to really make sure that patients can access service. We have, again, barrier reduction funding. So if you have something coming up, let's get a way for you to submit invoices, whether it's translation, interpretation, transportation, you name it, get in touch with us and let's think about how we can get resources out your way. Next slide. Care coordination. One of the things that we talk about here is really with that appointment setting. If your patient needs help in terms of making those appointments, contacting the GI, figuring out that work, that's something you can do as a liaison. Also following up with the patients about the procedure. It is never the role of the navigator to independently provide medical education guidance, or excuse me, not medical education, but it's not necessarily in terms of giving information about a diagnosis, abnormal screening results, or a recommendation about a medicine. You can do reminders, you can help back up a provider once they've shared that material, but it's never your role, of course, to be the one to share that diagnosis and the like. Having that said, when CCSP about 5 years ago, we did a follow-up survey with patients to only realize that about 25% of them were clear about when they should come back for their next colorectal cancer screening. It is imperative that once those doctors, nurses have provided the outcome of an exam, that you do follow up with the patient, that they're clear. And if they have questions, you can, again, be that liaison. But we want to just make sure that you have a role in terms of helping with that coordination. And if treatment is needed, oftentimes navigators from primary care working with treatment centers can help with that transition for the patient, whether it's basic needs, understanding who to call. So you really do have a role in that handoff as well as follow-up from colonoscopy. So some things to consider really about the role for CCSP navigators. Next slide. Insurance coverage. I know groups like Peak Vista, Denver Health, Salute, and others, I think, have specific sites where insurance coverage, there might be someone who specifically does this, but in some of our small and even in a number of settings that we know that you're looking at how do people access different insurance benefits and if they're eligible for certain programs. What I would say is, of course, CCSP is wide open. It doesn't matter what kind of insurance you do or don't have, as long as you meet that federal FPL threshold of 400%. You are able to come into CCSP in terms of being navigated and in the clinic being reimbursed. But having that said, we also know that you guys can also be the front lines in terms of thinking about how they enroll, knowing what they're covered, the idea that ACA covers insurance benefits. So I know there was a question whether basically lung cancer screening is covered every year. Yes, that's part of ACA and the preventive services coverage package. So that's something that you can do in terms of making sure they're aware that preventive services are covered if they are insured. And then in terms of understanding copays as well as in some of the deductibles is something that you can help with. At this time, CCSP is not helping with a lot of copays and deductibles because that would eat up our entire pot. Having that said, if there are monies at the end of the year, and I put out a shout out to everyone to say, you know, what do you have? Or if there are patients that need the support, we'll do the best that we can. But all of you can be very strong advocates for patients and helping them understand insurance coverage or getting connected. So that's something that we ask that all of you really try to make sure to do in your role of navigator. Next slide. And then the reminders, I can't say this enough. I really think that ultimately all of you being that fresh and friendly face, reminder colonoscopy before a colonoscopy appointment a couple days before about do they have everything on hand? Do they have the bowel prep? Are they ready to rock? Do they understand about the need for transportation because of conscious sedation? Do they know that they might need to have someone with them, of course, during that time of that procedure? The more that you provide these reminder calls and that you check in, the more apt they are going to be prepared. And there's also a lot of psychosocial stuff going on. I mean, I remember when I had my colonoscopy, my first one, my mom had colon cancer very young. I was in my 30s. I started getting panicky the night before. And it was really nice to hear from someone to say, like, you know, it's cool. Everybody gets a little nervous. Just want to remind you that you will be sedated. It will be okay. You have a team with you. And I remember how reassuring that felt. So making sure that, again, not just the day before, but a couple of days before, that they have that bowel prep, they're ready to go, that they have your phone number if they need something, and that you're really clear with the GI team about who's doing what, so patients aren't getting overwhelmed with a number of correspondence, whether it's from the GI nurse or you. And just again, what does it mean for those proper procedures and what's normal and what's abnormal? So these are the kind of things like getting in touch with patients, making sure they show up. The more that we have a steady stream and systemic process for reminders, the stronger we see the navigation working with patients really making it and having a quality exam. Next slide. Limits of navigation. So we actually talked about this before, no direct hands-on patient care. So no physical assessment, diagnosis, or treatment. So if you are a lay navigator or not a licensed individual, not providing information about diagnosis or treatment, giving in treatment plans or sharing or changing or adjusting any medical plan, if it's beyond the scope of the navigator for a patient to give you money, if you feel like you're in a situation where your institution doesn't allow driving patients to and from, I know there are a couple different systems that will allow this, and it's part of the purview and there's insurance coverage, but being very clear about what that limitation is. And maybe apart from an appointment, you're not driving them to other like types of gatherings or something that's a social event. visiting people in their homes, sometimes independent of a medical encounter or what have you. And then, really just being really clear about boundaries related to touching. And then I just want to say, patients, and we all know this, can be in really precarious spots. So if you're ever feeling uncomfortable, because you are that care provider, you are really helping that individual really think about access, but it should never be something that puts you in a bad spot. So make sure that you have a place to debrief, you have a strong relationship with your supervisor, and if something gets out of hand, either finding a way to hand off that person to someone else, or just reporting if it's really inappropriate. So protect yourselves, guard yourselves. You again are some of the biggest attributes that we have for this program. And so we want to make sure that you're taken care of and not put in a vulnerable spot. Next slide. And so one of the things I want to mention is I think most everyone on this call has already gone through the health navigation registry. So kudos to us. I think our program actually almost met this full requirement a couple of months ago, where we ultimately, the grant requires that there is formal participation in CCSP. You have to be formally involved in the Colorado Health Navigation Registry. So it's focused on lay individuals, unlicensed navigators, in terms of not having an RN, MSW, whatever it might be. CCSP can provide the training and the exam fees. We can help you link with PNTC to get ready, do some of the testing preparation. And then again, as also said, at least one of our navigators from all the CCSP clinics are now participating. We have resources. If you have other folks you want to have come through, you have transition. This is something that the grant will provide. And then we are required that each of our clinic systems have at least one member of their individual members on the registry. Elsa, anything to say about the registry?
I think you covered it. So I know, yep, we've had a few new folks in transition, needing to have at least one person from all clinics on the registry. And as Andy mentioned, let us know if there's any ways we can support, and we'll continue to keep you all updated on the status of the registry and implications for workforce development.
Yep. All right, next slide. All right, so Elsa, do you want me to say a few words, or do you want to just quickly talk about sustainability?
I was just going to touch on it super briefly because we did already kind of touch on this a bit, and clinics are already pretty far through the process. So just as a reminder, this is the last probably full grant cycle of CCSP. So we're trying to help support organizations have the practices in place and be able to adapt them as needed to continue to provide these services to patients even beyond the grant life. And so sustainability is funding stability is one really important piece of this, and being able to fund the work, but all the other components need to be strong and in place as well to really lead to a sustainable practice. So funding is important, but it's not the only piece that matters, and capacity can be built in several of these areas, and focusing on those that need the most support doesn't only have to focus on funding to help build capacity for sustainability. So these are all the domains. I'm not going to read over all of them right now, but we've had all clinic systems have a team of at least 3 to 5 individuals complete the sustainability assessment tool, and now most clinics have taken this assessment tool twice as they've thought about a sustainability goal and plan. And so we're going to continue to support clinic systems in the next 2 years in thinking about continued work on these plans, and if there needs to be adaptations made to continue to build sustainability capacity. So when we have our one-on-one meetings coming up, we'll touch base about what you want to concentrate on in the next few years, and weaving that together with some of that other capacity building work that we focused on as well. So we're here for you with any resources you need, and we'll be thinking about putting tools and resources in place to continue to have access to the supports, training, and technical assistance that the program provides right now, and thinking about other partners that can continue to provide these resources even when CCSP is no longer a formal program. And as Andy mentioned previously, thinking a bit about implications for policy and other avenues to continue to support this type of work and where we need to go in the future. All right. So we are now going to move on to the last piece that many people have been waiting for around reporting and evaluation. But let me just make sure there's no questions I missed in the chat. Okay, I think we're good. And if there's, of course, any questions of any of the pieces that we just went through that we didn't answer, please feel free to reach out and let us know. But so just thinking on a holistic level of CCSP evaluation, there's a few questions we're really trying to understand about how the program is working and what resources you all need when we design our evaluation for the program. So we're thinking about how health navigation impacts health outcomes, the patient barriers that exist, and what activities and processes are being implemented to help identify and address these barriers, all part of the work you all do every day. And then what training and technical assistance we can provide to you all to implement your workflows and provide those important navigation services for preventative cancer screening. And then the sustainability work, what capacity do you have and what resources are needed to support a sustainable patient navigation practice. So that leads us to our monthly colorectal cancer screening navigation report with colorectal cancer screening into visual exams and primarily colonoscopy still being the backbone of CCSP. This is our biggest evaluation piece. So as we are a practice-based program, not a research program, we collect that aggregate data monthly from patients navigated into preventative screening, not individual patient level data, except when we do our data audits. That's when we collect de-identified patient information, but really needing to know at an aggregate level the patient characteristics and outcomes. I've linked the monthly report link for the Qualtrics report for this new year that started July 1 here. We'll send that out afterwards as well, continuing to have reports due on the 10th of the month. And so we're really here to provide you with the training and tracking tools, and then supporting you with collecting that data and then providing the information as we highlighted some of those outcomes earlier. So I'll be walking through that report and the information needed to complete the report. This is what that tracking sheet that I've sent out previously in Excel looks like. And this is a really great tool for compiling your data for just looking at the individual patient level data all together, compiling that aggregate data as well as when you do those data audits. So I will send out, and I have already sent out the updated blank tracking sheet for this new fiscal year, but I'll send it out again if anyone hasn't yet received it. And so we'll be walking through a full report, and when we get to the section on endoscopy and pathology reports, really concentrating on looking at some of those example reports as well. But CCSP really looking at how many patients were successfully navigated, what the appointments attendance looked like, and then those outcomes and demographics. And we know that the evaluation reporting can be a big lift at times for clinics, especially those that have a large volume of patients that you're navigating. And so there were a couple of metrics that we were trying to collect in the last few years to better understand reach of patient navigation, but we did scale back a couple of these things to provide better, less of a burden for reporting in the next 2 years. So the only things that are different about the report this year is we removed the questions around outreach and inreach and the patients who were partially navigated, as well as that family history of colorectal cancer, because we know clinics aren't always able to collect that information, and we do have our dedicated work around family history as well. So without further ado, let me just again pause, see if there are any questions at that general level, but then I am going to jump into our example report. So let me just pause for a moment. All right, if we're good, I'm going to move on to our report. So many of you are familiar with what the Qualtrics report looks like. I'm going to be going through each question on the report, and again, we'll send out that updated link for this year that we've sent out in recent emails. Again, all of the resources for CCSP in one place, along with the recording and slides for today's training. But for the report, the initial questions we ask is getting a sense of what clinic system is providing the report. And some of you, like Valleywide, have several sites. So we ask if you're reporting for a specific site, and then who's submitting the report. So if there are any questions, I can reach out to that correct individual. And then finally, the month of the report. So as I mentioned previously, reports are due on the 10th of the following month. So if you're reporting data for July, so people who got their colonoscopy in July, you would select July 2021, even if you were submitting the data in early August. So I know there's been some questions on this in the past, just wanted to emphasize this again, that this is the month the data comes from, even if you're reporting it later on. And occasionally there are clinic systems who have data from an earlier month that they weren't able to previously enter, but then they do so later in the year, either through the audits or other times when they identify patients that they haven't yet reported on. You would still select the month that the data came from. Okay. And then the first section with the actual patient data is capturing how many patients were successfully navigated into colonoscopy. And then, of course, this also does include on an occasional basis when there were patients navigated into a different visual exam like sigmoidoscopy. However, that is rare, so we still say colonoscopy. But we want to know how many patients were successfully navigated into that colorectal cancer screening. And this does not include stool-based testing. So first we ask how many total patients were navigated, knowing that not all, you are navigating patients sometimes that are beyond the scope of CCSP eligibility. So occasionally you might be also navigating patients that don't meet that eligibility criteria, but you did successfully navigate them. That's that first number, total. That includes CCSP eligible patients plus any non-CCSP eligible patients that you successfully navigated. And then the second part of that is just that CCSP eligible patient count. So the total patients would also include the CCSP eligible patients plus any additional, and then the CCSP eligible patients only looking at those that meet that eligibility criteria. And that CCSP eligible patient count should match the number that you submit on your invoices for reimbursement. And that's the number that the rest of the report will really focus on. So appointment kept should be the same number as the CCSP eligible patients that were successfully navigated because they attended their appointment. We do also, for CCSP eligible patients, want to know how many patients were no-shows or cancellations, but those people were not successfully navigated into their appointment. So the appointment kept should match the number of people successfully navigated, and that number will be used for the rest of the report as well. Then gender and age category are the next ones. I'm not going to go into this in depth, but it's broken down by those different categories. And I will just mention for the Qualtrics report, it's always going to be calculating your total at the bottom with that gray bar, and it always needs to add back up to that number of appointment kept or CCSP eligible patients. And so if that is not the correct, if those numbers don't match, then this bar will be red. However, it'll give you it in gray, black, if it is that correct number and they match. If it's not matching, that's because it's a different number from this one. Okay, then the next ones are race, ethnicity, and payer source. And for both of these, need to count each patient only once. We know there might be more than one category that they identify with, but really thinking about that primary. And so for payer source, for example, someone might have both Medicaid and Medicare. In that case, Medicare would be reported because Medicaid is that payer of last resort. So if a patient has another insurance type, that one is the primary if they also have Medicaid. So for each one, just reporting each patient only once. That's how the program has always collected data. So trying to stay consistent with how data has been historically collected for the program. Now is when we're going to move into endoscopy and pathology reports, which I know you've all been waiting for. So thank you for sticking with us up to this point. So as Andy mentioned previously, endoscopy reports, every single colonoscopy will and other visual exam will have an endoscopy report, which is really just an overview of the screening, how it went, but then if anything was taken out of the colon, that's when there will be a pathology report. So really important to understand these reports and be able to interpret them, to help your patients make sure they understood the results that were provided to them by the provider, and making sure you understand what follow-up recommendations they received. Not able to give opinions or medical guidance, but really helping make sure patients got their results, understood their results, as well as reporting those outcomes for CCSP and helping navigate patients who need any follow-up or treatment. So endoscopy reports contain information about the patient characteristics, that risk level, the indications for the procedure, why they needed it. They describe it, what those findings were, how well the exam went, what the provider saw as the assessment, and what those next steps are. And that will tell you whether or not any polyps or other tissues were removed, and how well the patient tolerated the exam as well. So this brings us to our example activity that we had you all prepare, if possible, ahead of time. So this is an example endoscopy report. It contains all of those components I just mentioned. This one is an example, so even though it has what looks to be some identifying information, this is just an example report, doesn't contain any information from any real patients or physicians. But we wanted you to try to find some things in this report: the patient age, the colonoscopy reason for CCSP, was it screening, diagnostic, or surveillance? Was the cecum reached? What were the outcomes? Was there a pathology report? And was there any tissue removed, and how you would categorize any findings? And then what were the follow-up recommendations for the patient? So I'm going to take a moment, pause here, and maybe we can call on a couple people to help us identify some of these elements. And if you did the activity ahead of time, this is the exact same thing that we asked for then. So I am going to call on Anna, because that's who I see in front of me first. Anna, could you tell me the patient age and the reason for their colonoscopy based on this endoscopy report?
Yeah, the patient's age says that he is 60. And I am not sure about the reason, because on top it says for an elective colonoscopy, and then on the bottom an indication it says because he has recent bleeding pain, so that's more like a screening, correct?
So for this one, yes, the patient is 60 years old, and the indications is where that reason for the colonoscopy is found. And so this one, it's showing that they have recent bleeding and then abdominal pain. And so those would be signs and symptoms for colon cancer. So that would be a diagnostic colonoscopy.
Okay.
So screening being that they didn't have any signs or symptoms, surveillance being if they already had a prior colonoscopy and had a normal result, needing another colonoscopy at a follow-up interval. This one being diagnostic.
Okay, what threw me off was the elective inpatient colonoscopy.
Yes, and I can follow up with you on some more detail with that and the difference between those. For time, I'm just going to move on, but that is a good thing to bring up, and I can definitely provide some more information about that. Okay. And then for the next one, can anyone tell me if the cecum was reached? Yes.
It was.
Laura. Yes. Great. And so this will tell you that the colonoscope was advanced to the ileocecal valve. So ileocecal valve, cecum, terminal ileum, all of those things will tell you that that's reaching the cecum, reaching the end of that colon. Okay. And then was there a pathology report? Was there any findings or polyps found? So Julie, Gloria, Tammy, one of you?
Yes.
Great.
There was a polyp found.
So I am going to move on. And all of these things are highlighted. There was a large sessile polyp found. I'll show you how that's categorized in just a moment, but showing that that was removed. So there will be a pathology report. And then what that recommendation for when the patient needs their next colonoscopy also there. Okay, so all of those questions will be asked again. Usually the endoscopy report also tells you if the prep quality was either adequate, not adequate, excellent, or good. That one wasn't on this one, but that should be in there as well in general. And again, appendiceal orifice, ileocecal valve, cecum, all of those things will tell you if the cecum was reached. So pathology reports will tell you about the different polyp types and what that outcome was and confirming those recommendations for that patient. So print this out. We'll send out the direct PDF for this as well, but this is how CCSP divides up categorizes the different polyp types. This was developed in concert with our medical advisory team. And so with Dennis Onen and some of our other folks at CU really helping us determine the best ways to categorize the many different polyp types there might be. So for that particular example we just had on that endoscopy report, that one was a sessile polyp and it said it was large. So the actual pathology report should have a better description of what that finding really was for that polyp. But based on what the information we have from that endoscopy report, it was large and it was sessile, so that would put it under that high risk or advanced precancerous polyp. So those are the ones that are most likely or at the closest stage to developing into cancer. As Andy touched on earlier, some of those ones in that benign smallest category have the least likelihood of developing into cancer, but they're still going to be removed in almost every case from the colon during that colonoscopy. And then precancerous, more likely to develop into cancer, but not as high risk as those ones in that next high risk and advanced category. So really familiarize yourself with these different polyp types. Let us know if you have any different questions. And two things to really focus on when looking at the endoscopy and pathology reports and trying to determine the correct categorization is the size of the polyp, as well as any dysplasia and level of dysplasia that it has. So for example, some of those sessile serrated polyps, if it's smaller than a centimeter without dysplasia in the precancerous category, but if it's larger than 1 centimeter and has dysplasia, moves up to that high risk and advanced categorization. So we'll do another round of training around this in more detail, but those are the things to really look out for. And please let us know if you have any specific questions as you're looking at your patients' endoscopy and pathology reports for the reporting. Trying to help make sure clinics are putting them into the right category, not doing them, reporting them all as benign, because even though it is not a cancerous polyp, there's still different levels of risk in different polyp types. So here's an example of what a pathology report looks like with that final diagnosis. This one is a hyperplastic one without dysplasia, so that would put it as a precancerous one. For hyperplastic polyps, if it's large and or has dysplasia, can move from that benign category to that high risk category. So that's really important. This one showing the size. As Andy noted before, it'll show you where it was located in the colon. This one at the appendiceal orifice means it was at the location of the cecum. And again, it'll have what that final diagnosis was. So that's how you'll report it on the report, just in those main categories. And then we also ask, the last questions on the report are referrals between other programs, because as Andy mentioned, great opportunity for referral into all of the different cancer screenings that a patient is eligible for. So WWC, and then some of those other interventions as well, even if it's not cancer screening, and then barriers and barrier reduction. So read through some of these tips for accurate reporting. Really want to focus on the different polyp types and categories, making sure your clinic has a process to track no-shows and cancellations, as well as those cross referrals, making sure you're clear on that CCSP eligibility criteria, including the different reasons for getting a colonoscopy, as well as that age for the guidelines. And then please let me know if you have any additional questions and need any additional resources, and I'll send out all of these resources we went over today. I'm not going to focus too much on billing today because we are about out of time, but as I mentioned previously, when you are completing your monthly evaluation and invoicing, that number of CCSP eligible patients that were successfully navigated into colonoscopy or other visual exams should match for billing as well as the evaluation report. If there's any reason why they don't match, if you know why, please let me know. But if there are some of those discrepancies, I will be following up with you as well. Those get submitted to our finance team, and this should not say Lori Workman, that's outdated, but with Kelly and Barbara from our finance team. I'll also send along their contact information in this follow-up. And this is what that invoice looks like. So just how many patients receive that patient navigation. We're expecting that you've already checked they meet that income criteria, as well as that they did successfully attend their colonoscopy appointment. And then for barrier reduction, we'll send along that form as well. But why you're requesting it, please send that along to us using this form and receipts if you have any of them as well. So this is the information, just send it along to us. We'll make sure it fits the criteria and pass it on to the finance team, and we can only reimburse that clinic. And we've already gone through some of those examples of what things are eligible. So this is just a page of our different resources, and that is everything for today.
Hey,
I do have
everybody.
a question, Elsa.
Yes.
With regards to entering into Qualtrics, like, so you've entered individually for, you know, the month of July, now in August, but you forgot one that was done in August and you want to enter it in was done in July, you want to enter it in August. Sometimes Qualtrics won't let you go back in if you've already entered for that month. Do we reach out to you then?
Yeah, it would be great if you could reach out to me to let me know you have more data for that month. And then I'll have you submit a separate report just for that month. You can submit more than one for a month for Qualtrics. It won't let you edit a past report, but you can submit more than one for a single month.
Okay, cool. Thank you.
Absolutely. And yes, I know we're just a couple months or a couple minutes over time. So I know some people have to run, but big thank you for all your time. I had a lot of fun getting to know some of your truths and different lies going on. So really fun to learn more about everyone today. And thanks so much for engaging with us. And please let me know if you have any follow-up questions, and I'll send out all of the resources from today's training early next week. So thank you so much, everyone. I hope you have a wonderful rest of your weekend. Take care, everyone.
Thanks, everybody.